questions into the chat, and as we have time, we will make sure that we take questions both from those in the room and those who are joining us online. And with that, I am going to screen share, and you all are going to have to also bear with me that I'm not like the technical person. So appreciate everybody hanging in as I go back and forth between the screens.
Can you guys hear me? Great, here we go for you guys. Awesome. My turn. Hi. All right, I'm Gene Quinn. Despite my formal appearance, I am actually an Alaskan doctor. I know we don't usually wear this type of clothing. Actually, my 8-year-old this morning, when I said, "Hey, how do I look? I can give you a presentation." She said, "I feel like you should wear a tie." Nobody will trust me if I have a tie. So I'm Gene Quinn. I'm a cardiologist at Alaska Heart Institute. I'm also Chief Medical Officer of Envoy Integrated Health, and I'm very proud to be the board president of Healthy Connect, which is Alaska's health information exchange. And this is our first annual summit. So excited. Thank you everybody for coming. This is amazing that everybody came. All the people virtual as well, and our moderators and our speakers and panelists. It's pretty impressive how many people we have that are national experts that have flown all the way up to our small and also large state of Alaska. So thank you guys so much. So who are we? Who is Healthy Connect? And also, I wander, so if I get too far away from the podium, then I have to run back. If you guys see me over here, let me know that I should be back there. Who is Healthy Connect? We are Alaska's neutral nonprofit health information exchange. We're locally operated, we're locally located, and we are locally run by a board of directors that includes stakeholders from across healthcare, and that was on purpose. We wanted everybody to be engaged, everybody that has a say and a interest in the healthcare of our community. And so that's private practice providers, Hospital and Nursing Home Association, community-based primary care, VA, tribal, healthcare consumers, the commissioner, University of Alaska, business and employers. All of these people have a vested interest in the health of our community. I usually have the number 1 bolded because I've heard that he's just a really cool guy. That's me. I didn't hear a lot of it. If you guys don't think that's funny, it's gonna be a long. All right, we're no. What happened to my my presentation mode went away? So. It is working? Okay. So what do we do? It should be what do we do? Yes. All right, the chat. This is actually really great. I like that there's a virtual thing. I feel like I don't usually get enough criticism just at home. Like, chat can also be like, actually, you're not very good at this. So what do? We are, you'll see it soon. We are neutral stewards of health data. It's really important to have as much of a rich source of data so that we can do population health, public health, healthcare in our state. I don't know if you guys have noticed this, but the healthcare system in Alaska is kind of fragmented, right? That fragmentation makes it really difficult to coordinate care of patients. You go to one system, you may not be able to see the records from another system. This, the health information exchange is really critical infrastructure for being able to coordinate care, for being able to achieve any of the goals that we want to around healthcare cost, healthcare quality, or population health. You need to have this rich source of data. Okay. Good.
We'll get it.
I actually knew what was on that slide. That's amazing. That's what Doesn't my medical record already do this? Yeah, not really. I mean, maybe, like, it might do a little bit of it, but kind of not. So let's think through this. Let's ask our medical record system a simple question. How many of my diabetic patients had a systolic blood pressure above 140 at their last visit? Well, if your medical record system is a file, you can ask it as much as you want. People might look at you funny because you're talking to a piece of paper. Really? God, this is a really hard crowd. This is gonna get worse. Yeah. But obviously, it can't answer this type of question. It's an important question if we're talking about taking care of patients, not just one at a time, but as a population. You could take that entire medical record system and scan it all into one PDF. Probably need a pretty big copier, but you could do that. And then you could ask it that question, but it's still just one PDF, right? Technically an electronic medical record, but it can't really answer that question. You can sort that out and you still have PDFs, but we really need that unstructured data to become structured data. You can't just take data from anywhere in a medical record. It has to know where you're trying to pull it from. So that is something you can actually ask that question. Let's ask it a harder question. Let's say how many of our diabetic patients, a group, this could be Alaska's, this could be one health system, this could be a couple of health systems. Diabetic patients have chronic kidney disease, proteinuria, and a hemoglobin A1C above 8, but haven't seen a nephrologist, a kidney doctor, in the last year. These people are at really high risk for progressing to diabetic nephropathy and eventually end-stage renal disease. That has a lot of morbidity for the patient. It also has a huge amount of cost for the healthcare system. So these are people that, in theory, would like to identify early and maybe have an intervention to save them from this disease, right? How do you do that on a population basis? I guarantee it's not just the one EMR. You really have to have a rich data set that can take all of these different EMRs, all of the different practices EMRs, understand their language, put it into one spot where it can be used for treatment, it can be used for public health, it can be used for improving the healthcare of our community. And that's really what the health information exchange is. It's this critical infrastructure that is required if we want to make Alaskan healthcare system less fragmented and be able to achieve the goals that we all agree are important. Good news is that Health Connect is flourishing. It hasn't always flourished, but it is now. We have a strong board. We've already talked about how great the members are, right? We have a strong and engaged board with an established governance. We're now an affiliate of CRISP, which is a technology stack that's shared by multiple different states, so that we now, as Alaska, a large but small state of 750,000, have the same best-in-class technology that a state with millions of people would have. We're endorsed by multiple organizations, including the State Medical Association and the Hospital Association. And then we've had rapid growth over the last year. The number of users, so this is just from 2021 to 2022, has doubled. Our participating organizations, the amount of connections we have increased by 40% over just this last year versus the 10 years that it was before. Our event notification traffic is 26 times higher. And just in the last 2 months, we've had 45% more providers searching for patient information through the Health Information Exchange. And a lot of this is because we've had engaged stakeholders from across Alaska. There's been a lot of conversations about how do we meet the community's needs and how do we be the health data utility for the state. So the day ahead, the summit's all about collaboration, innovation, and interoperability. You're going to hear from a lot of health IT leaders here. They're all working together for a healthier Alaska. Hopefully, you'll have some time to interact with them. You may be able to clap if you think they do a good job. If you think they do a not so good job or they say something you don't like, under each of your seats is a small basket of tomatoes. We're still doing the tomatoes, right? I'm sorry, probably a survey. There'll probably be a survey later. The tomatoes were mine. Whatever. Thank you for anybody that actually laughed. It's super funny in my head. But I really want you, this is a little soapboxy and I apologize, but I really want to encourage you to think about your own institution. Think about where you represent and think about what its vision is for how it's a part of the healthcare system. How is it a part of improving the healthcare of our community in our state? And try and think, what is, with all of these other people talking, who else can I collaborate with? What is my role in making sure that infrastructure exists and that our healthcare system is less fragmented, less siloed? How do we create the bonds between those silos so that everybody can be here? Thank you so much.
Are secondary to this. Alaskans with chronic and complex health needs often face many challenges receiving care and services. The lack of critical and timely information across many health providers, health agencies, health and social systems make it more challenging for referrals, ongoing treatment, and travel for specialty care. This translates to delays in receiving preventative and primary care, or simply not receiving this care at all. As a result, Alaskans end up in the emergency room or in jail, which is both costly and preventable. For healthy Alaskans, I encourage you to come together in a collaborative and innovative way. In some instances, this means using Alaska's Health Information Exchange to view medical or referral information. In other instances, it means piloting a new idea, process, or technology, or discussing best practices to meet state and federal data privacy rules. I hope today's conversation is the start of many conversations and ideas. Thank you for joining us today. And last but not least, thank you, Healthy Connect, for pulling this event together.
Right. And now I would like to invite up our first panel, which you probably can't hear me. And now I would like to invite up our first panel to come and speak to us about the community and Healthy Connect. Yeah.
There's only 3 of us.
Some of them are
They thought that was the end of the jokes, which they
Would someone online please comment if you can hear us okay? Don't say no.
We're getting there.
All right, everyone, I'm Kat McDevitt. I'm Partner and Chief Strategy Officer at Incentive. We're a health tech strategy firm, and we've been working with Healthy Connect for a couple of years now. I'm very excited to be the first moderator of the first panel of the first Healthy Connect Summit annually, which will happen next year. Maybe it'll be the second one next year. Very excited to have a number of really cool speakers for you all talking about how the HIE really supports the community in Alaska. My consultancy works with HIEs all over the country, and Alaska is so unique and so cool. And I think the things that all of these participants here have been able to do over the past year, and some even more closely to today, have been able to do is really cool and something that we should be sharing with the entire country. So I'm going to give a brief overview of each of our panelists, and then they're going to deep dive into some of their experience with the HIE, and then we'll go into some open discussions. So to start, we have, as you just heard, the amazing Dr. Gene Quinn. I'll let him introduce himself more specifically again, but he is our president, the Healthy Connect board president. We'll ask him later why he is the board president and not something else. He's also the chief medical officer at Alaska Heart and Vascular Institute and a practicing cardiologist. We have Lori Roy. She's the director of operations at Envoy Integrated Health, working with Dr. Quinn on some new projects across the state and locally here in Anchorage. And we have Joshua Arvidsson, who is the Chief Operating Officer at Alaska Behavioral Health. So we're going to start with Joshua deep diving a little bit into his experience with Healthy Connect and overall his experience and background working in Alaska with behavioral health. I don't think you have slides, but that makes it even better. We'll change it up.
You know, I've done the BP Center slide rodeo before many times, so I said I'm just going to talk this morning. Save a little bit of stress here at the start. So I'm Joshua Arvidsson. I'm the Chief Operating Officer of Alaska Behavioral Health. I recognize about half of you in the room, so it's good to see you. A lot of you. It's nice to be back in this room. It's been a couple of years. So when I was invited to come here today, I'm kind of pretty new to this. I feel like I'm jumping on the train as it's leaving the station. A lot of people have spent years building this system up, and we just made access possible for all of our providers. We have close to 200 clinical providers and medical providers in Alaska Behavioral Health. Made access to the HIE possible through CRISP. I recognize that. That's the button I click in our EHR, a CRISP button, for all of our providers 8 weeks ago. So we are brand new to this. I am on fire about it though, because I can say in those 8 weeks, this system has improved the care that we provide to our patients and that I provide as a clinician to my patients. And I'm really excited about this. And I think it's probably already saved some lives in our system. It's definitely saved some fingers and toes and improved some outcomes for some of our really complex patients. So I'm going to talk a little bit about what I think this can mean for the behavioral health system and behavioral health system as a part of a larger health system that can be more effective for Alaskans. So I'm going to talk a little bit about what we do. We are a certified community behavioral health clinic. We operate 2 of Alaska's 3 CCBHCs. A CCBHC is a center that meets a set of SAMHSA best practices for behavioral health. It means you provide a continuum of care. We do everything from street outreach through outpatient care to active PHP, partial hospitalization programs, and then provide care across the lifespan. We provide services down to the age of 3. Sometimes folks are like, what does behavioral health for young kids look like? I'll just remind everyone that half of the child protection reports that the Office of Children's Services receives every year are kids under the age of 8. So there are a lot of little kids in Alaska who need help. And then we provide care all the way through to the end of life. That continuum of care looks like everything from the therapeutic preschool and outpatient clinic for young kids, Alaska Child Trauma Center, 3 outpatient clinics, an ACT team. Some folks know what an ACT team is, assertive community treatment. If you've never heard of that before, this will tell you most of what you need to know about an ACT team. It's before 11 o'clock on a Friday, so my ACT team is at the Sullivan. That's where they're at right now. And they're doing outreach, and there's a clinician, a peer support specialist, and a CA out doing that kind of work every day in our community, serving some of our clients with the highest kind of needs community who are high utilizers of other healthcare systems. We have the intensive case management teams, and then we run 24-hour mobile crisis team in Fairbanks. The reason I wanted to provide that kind of spectrum is to talk about what this can mean across this behavioral health kind of system and how it can improve care. So like I said, we just jumped on this train and we're really excited about it. Just a few days after we made access to the HIE possible by literally clicking a button in our EMR, I was doing short-term crisis intervention coverage in one of our clinics. Sometimes I'm called the clinician of last resort by our front desk, because unless I'm literally, in front of a microphone, I can be called out when we're running at full capacity to handle a walk-in client. And so I was meeting with a client who had some very complex health and co-occurring mental health conditions, and it had several recent emergency room visits. 6 months ago, I would have been operating to a large extent on what this 17-year-old was able to tell me about the healthcare she had recently received at a local emergency room. But now, with the click of the button, I could see exactly what was happening and engage my client collaboratively in planning for what she needed for her mental health care, which was very interrelated to what was going on for her in her other physical health as well. And that made me a believer. So it took about 48 hours for me to say, this is going to improve the care of the clients that I serve as a clinician. As COO, I get to work with teams across the company. So I'm just giving you a little bit of a glimpse about how I think this can change the care that we provide. So like I said, some of our teams are out in the community. Our mobile crisis team in Fairbanks is dispatched by emergency dispatch. It's a clinician and a peer support specialist. There's a whole decision tree for deciding whether it's a law enforcement response first, fire department, us, or a combination of those three. Sometimes it's us primary with law enforcement on standby, sometimes it's law enforcement with us on standby. And now with this system and some new mobile technology, that team may be dispatched to someone's home at 2 a.m. who is having thoughts about killing themselves. That team has access to that patient's information. They know where they're getting their care. I'll give you another example from our ACT team, working with a client, encountering a client in shelter or on the side of the road or in an assisted living facility, and they clearly have a wound. And we ask them, have you had that looked at? And they say, yeah, I went to the emergency. I went to the hospital a couple of days ago. And we served 829 clients with a diagnosis of schizophrenia last year. So some of our clients are pretty disoriented when we're engaging them. And we asked them, what hospital? And they say, the one with the emergency room, right? So they're disoriented. And just 3 months ago, while we're transporting that client back to our facility, because we do have integrated primary care to get their physical health need addressed, I would have had a team of case managers scrambling, working the phones, working the fax lines, trying to figure out where this client received their care. I mean, with alerts now, we probably actually know this as the minute we saw the client. So it's different, and it's really exciting to see what a difference this can make in the care that our clients are seeing. Because now today, we know more than they went to the hospital that has an emergency room. We actually know what care they received, what the follow-up is, what the discharge recommendations were, and how we can coordinate care. So we're really new to the system. We're working towards becoming a contributor to it, not just a user of it. And I think it's going to really improve the outcomes for our clients. That's important to me. So adults with a diagnosis of schizophrenia have a life expectancy that's 15 years shorter than the general population. We got to fix that. And this is going to be part of that. So thank you.
Thank you. And if I could ask Lori and Dr. Quinn to move your microphones a little bit closer so that when you speak, our virtual attendees can hear you. That'd be great. Love the patient and client journey. I think that's really powerful to show how this really impacts people directly. We're going to have Lori go next and talk about some of the really cool programs she's been able to facilitate by being a member in Healthy Connect, and also talk about her journey to get to where she is now with her many integrated practices. And I think she has some slides, so hold on just a second.
So I've had the opportunity to work. Can you hear me, guys?
Yeah, pull closer.
Got it.
Right up in your mouth. Yeah.
So I am very fortunate. I've had the wonderful opportunity of 20 years working with direct patient care. And the one thing I can tell you is we are not in the business of selling washer and dryers. We're in the business of patient care, and everyone in this room today and everyone joining us, I think we have the common goal of improving the health and well-being of our patients and our citizens. So I am very fortunate. I'm working with Dr. Quinn as well as the Envoy CIN, which is a clinically integrated network where independent practices have come together for the primary source of improving everything that you just heard about today, the communication, the collaboration, and improving patient care. And the best way to do that is through data sharing. So when I got here, I've been in Alaska a year and a half. The first thing that I was asked to do is work directly with the HIE and start building roadways, interfaces, so indeed we could start collaborative care. So I have to say, I almost think we're close personal friends because it's been a daily, if not weekly, project as we work with now 31 practices and almost 300 physicians to build the infrastructure with the HIE to be able to share this critical patient data. My focus beyond that has also really been focused on working with partners such as the Department of Health. And the Department of Health has really asked Envoy, again, we have primary care practices and the opportunity of really being able to reach out and help patients that smoke find a way to quit. We have an amazing Alaska quit line. Currently, that process is very paper. Pull it out, fax it in, and cross your fingers that the patient is contacted and that they follow the process. The quit line has an amazing process that can truly help our patients quit. But it's paper. And so when I arrived, I was like, oh, I have a dream. Georgiana, did I have a dream?
You have three.
I had a dream. I really believe that if we could embed in an electronic format that referral within an EMR that could electronically get to Optum, which is the quit line, we would have less errors and actually have something that is sustainable and, more importantly, measurable. But what did that require? A whole lot of systems speaking to each other that aren't supposed to speak to each other. So we had to build a roadway or interface with a number of different systems to make this happen. Georgiana was smart, and the HI team, they knew they could do this. They assured me we could do this. And so we chose a pilot. We started to work with one of our primary care practices, but at that same time, we were working on building an interface. So the timing was perfect. And what we basically did, if you're a practitioner, you know within an EMR, you have order sets. You basically, that's how you order an x-ray, that's how you order a lab. It is built into every EMR. And the HIE team had a fantastic idea. That's exactly how we'll build this referral. So in essence, the patient is in, seeing a physician, and of course you go through history of physical, and smoking history is very important to that. If that patient says, yes, I think I'd like to quit, and I would certainly want a referral to the quit line, we are able to electronically send that referral to the HIE, which then electronically sends it to Optum, which is the organization and technology that works directly with the patients. And what's really cool is that referral is over here in the EMR. The referral travels through time and through the interfaces. And then Optum does this thing, the quit line works with the patient. And amazingly enough, that outcome travels back through the HIE and back over to the EMR, which in this case was Cerner, and directly populates that patient. So think about that. No longer are the physicians going, well, I referred that patient. Let's hope it worked. We now are going to be able to truly follow that patient and provide, long-term care around their smoking and know if they did or did not and help them through that process. I think this is very exciting. I almost want to do an amen that we were able to figure out how 4 systems could truly speak to each other, and it can be done. If there's one message is, we have a lot of different systems in Alaska, but it can happen. We have some amazing people at the HIE. We have amazing IT folks at each of the EMRs, and it can be done.
Thank you, Lori. And I'm curious to know too, with the Quitline, have you been able to look at any actual outcomes now that that process has been automated?
So it is so brand new. Like, it's just happened.
So the second annual summit.
I will
We
have
are
a
the
full
second
report
one.
for you.
Got it.
But now in practice, not only will know the result of what happened with that patient, we'll also be able to understand where the majority of the patients live, what are the ages, how effective are we? I mean, that information is so critical around population health and the care of the patients that it will be fun to come back next year and report on how we do it.
Perfect. We'll look forward to it next year. All right, and Dr. Quinn, I know you have some slides as well. Would you mind reintroducing yourself briefly with some better jokes? And also tell us, if you can, during that opening part, why Alaska Heart chose to join the HIE and why you chose to become board president of Health Connect.
Wow, that's a lot.
Now,
I actually already used up all my jokes in the first session, so don't worry, there won't be any more. So I'm Gene Quinn. Like I said, I'm a practicing cardiologist at Alaska Heart Institute, which is the largest provider of cardiovascular care in the state. Also chief medical officer of Envoy Integrated Health, Lori's organization that is a clinically integrated network of now up to, or just recently, 31 independent private practices that have come together for the purpose of improving coordination of care, improving population health, and breaking down those silos that we were talking about. What else? I'm also the board president of Health Connect, which I do because of
the other title he wanted was taken.
Oh, yeah. I did. That was a joke that I wasn't gonna do.
You told me last night we were drinking, you were gonna set it up. Anyway, all right.
I know what she's talking about, but I do know that, yeah, I'm president because they wouldn't let me change it to emperor or supreme leader. It sounded better.
Yeah, well, we can do a rebrand. But I know you have your slides up here.
Do you want me to click? Do you want me to click?
Are you feeling like you should stay at the podium? You tell me.
Press the button.
The button isn't working.
Yeah, I knew when you were moderating this that I would be.
Just so everybody knows, I was a last minute shoe in.
So, medical school, I went to it. I recommend it for most doctors. Too much. In medical school, you learn to take care of patients one at a time. You have this great rapport with them. That's kind of what's seen on the upper left. No, you don't see that on the upper left. By the way, so this is the BP Energy Center. It's this is our first time here. It does take a little bit of time. I'm apologizing for these new systems. You know, if PowerPoint and presentations had a health information exchange, or they all like talk the same language, you could have just one slide, right? That'd be awesome. Okay, good. On the lower right, that's more like my patients, I think. That guy's like, man, I don't really like what you're saying. It looks like the guy on the left is trying to give me bad news. Not interested. But it's a very different thing than population health, where you learn to make evidence-based decisions about an entire population. And that also takes a very different infrastructure. And like I said, Alaska's healthcare system is incredibly fragmented. We see ourselves as in any individual silo doing a really good job, but that doesn't mean that it's good for patient care. and care coordination when you can't cross through those silos. And infrastructure is really key on that. It takes more infrastructure than any one private practice or any one small practice can provide to be able to do that type of coordination. But we need to be able to coordinate if we're going to deliver true quality of care, true population health, value-based care, cost savings, any of the things that we're talking about. This all takes an infrastructure. So really what you're trying to do there is draw lines between practices. That's what Lori and I's institution Envoy is trying to do, is to try to break down these silos, have more coordinated care between the different practices that exist in Alaska. And it's that same type of thing when you're talking about how do you interact with the health system, how do you interact with clinics that are outside of that network. If your patient leaves that network, you want them to get excellent care. You want them to get excellent care no matter where they go in Alaska. And that's why a Healthy Connect is so important, is because it takes all of those different systems. So I say that we have 31 practices. I like to say that we have 31 practices and 40 different EMRs.
I can attest to that.
Yeah, exactly. To integrate all of that and to have one set source of data. And that's what that we use the Health Information Exchange for. It's not just information sharing, which is super important so that we can eliminate waste. We can coordinate the care of our patients between different sites and start to have that quality improvement. But also it provides that infrastructure for population health that Lori's talking about when they say, well, how do we do the quick one? How do we get our patients to quit smoking? Alaska Heart has a lot of patients that either have smoked or smoked. I would consider those patients some of the highest risk smokers in the state because they already have organ damage, right? They already have cardiovascular disease. How do we have a way for them to get evidence-based smoking cessation at the point of care? And that's exactly what Lori's project has done, is be able to build from that infrastructure a way that's actually actionable and impacts patient lives. There are other things that we can do, right? It doesn't have to be just smoking cessation. You guys heard of this thing, COVID-19? It was kind of a thing, and it's still kind of a thing. And in fact, a lot of patients have not had boosters. So booster uptake is about 19% of the adult population. And vaccination information from Backtrack, which is an excellent program that is centralized for Alaska for all vaccines to vaccine data to go into. It's not necessarily as easy to find at the point of care in your EMR with that easy click that you're talking about with smoking cessation, or with that easy click that you're talking about with being able to get information on your patients that are experiencing mental illness. And so that's a great spot for Healthy Connect, right? For a well-functioning health information exchange that connects all of us. So the Department of Health and Healthy Connect partnered with one of my favorite institutions, Alaska Heart Institute. Yeah, thanks. Seriously, you just laughed just once. It's polite. So in that, the Department of Health made that vaccine data for COVID-19 available within the Health Information Exchange. And the Alaska Heart Institute said, we're going to take this and we're going to do a pilot study. We're going to create a workflow where all of the patients that are going to be seen by a certain subset of providers are going to, we're going to look the day before, figure out which of them are eligible for boosters, and then provide that information to the care team, who's then going to give a strong recommendation to those patients about, or at least know that they should give a strong recommendation about getting a booster. And we're going to stock booster in-house. Before COVID-19, Alaska Heart never did any vaccination. There's a sense in a lot of specialty practices that vaccination, smoking cessation, other things like that are primary care. But now that we realize that we are part of a larger system, that we're breaking down these silos, we realize that every time that a patient touches the healthcare system is an opportunity for preventative care and for care coordination. So we had that, and that was the study group. The CMAs and physicians would offer that booster. And then the bivalent booster was also available to all of the rest of the group. So we told everybody, this booster is available because we wanted to have a comparison group that was fair. You can't just say, all right, tell everybody else, oh, this doesn't exist, and now you're the control group. I mean, I don't know much about science, but I think that's that. And here's what we have. This just started, and this is last week's data. The last week, Alaska Heart saw about 700 patients in just its main clinic. We have 4 clinics, but we saw 700 patients. Of those in the study team, Team B, about 82 of them were seen. 30 out of 31 of them who had, so 31 qualified for a booster. 30 of them were offered that booster, so that was one of our metrics. I'll be honest with you, that 31st person was me, and I didn't offer it, but he did. But he was like actively like clutching his chest, and we did have to take him straight to the hospital. So I thought maybe next time. And out of that, 6 patients were vaccinated. I mean, the comparison group, 623 people were seen, and no vaccines were given. If we expected that same rate, there should have been 46. So, and the statistics, it is highly significant. It's actually really difficult and kind of unfair when you've got 0 in one group. But the point of the story is that I think that we can very confidently say that this process, through the health information exchange, through making that data available at the point of care, can improve population health and improve the rates of COVID-19 vaccination and boosters. So the pilot will run 30 days, or we could expand it, but it doesn't have to be just vaccines. There's lots of different things that we can do. We already talked about spontaneous cessation. I guess what I want to leave you with is, what's your project? What's the thing that you think would be great if we could implement it across different silos in the healthcare system using the health information exchange?
And you can ask those questions in 15 minutes after I'm done. Yes, right. So,
I also want to add.
okay, you add that on quick and then we'll pivot over to Joshua. Okay. I thought I was in charge.
So again, I wanted to mention, because we have built this process, we don't have to rebuild the whole thing again, which is huge. So where the point of the HIE referral going to Optum and coming back into the HIE, that's done. If you have Cerner, it's really done, because Cerner's also built it, now knows how to do it. You don't even have to be in practice with an Envoy to automate that referral electronically. The other thing I have to say is this does not happen without the folks at the HIE. They manage the project. They work directly with the vendors. They keep me calm during the process and assure me everything's going to be okay. And at the end of the day, they also save us a lot of money. If we were to build these interfaces, it would take multiple interfaces and be extraordinarily expensive. So I want to personally thank the Department of Health, the HIE, and all the folks to make this happen.
All right. So despite the fact that I run a health technology consultancy, I get super bored hearing about technology things. And what really I think brings these projects to life is talking about use cases, right? Talking about programs like you all just mentioned. The client-patient journey that you mentioned, Joshua, is really phenomenal here. So I'd love to hear more. And I want everyone in this room to know it is really unusual across the lower 48, don't know about Hawaii, but definitely across the lower 48, to have behavioral health really participating in an HIE, and for behavioral health to be really integrated with physical health in any community. So I want to acknowledge that it's very cool. I know it's only been a few weeks, but phenomenal that is already happening here, facilitated by the HIE. So Joshua, I'd love to hear more. You shared some great client stories and some of the programs that you're supporting, but what's next for y'all? How do you hope to expand?
Yeah, that's a great question. So one of the things that we're working on that the HIE is going to be really critical to is access. We've been working really, for those of you who I've known for 20 years and haven't seen me the last couple of years, it hasn't just been COVID. We've been really busy working on access and capacity. The time to provide someone with a mental health service is the day that they ask for I've been a therapist for almost 25 years. I'll tell you, it's actually about a month before they ask for it, but they have to ask for it. So there's a stigma and all those things, right? By the time someone says, I need help, they really do need help and they need it now. And one of the things is we're a specialty, right? Behavioral health in this big health system, right? So, you know, I've lived in Alaska almost all of my life. If I show up at Providence, once they've got my name and my date of birth, they know who I am, right? But I work in the behavioral health system. There's a fair amount of people who walk in to our clinics, interface with our teams, interface with our mobile crisis team, or walk into one of our walk-in clinics, and they're brand new to us, but they aren't a brand new patient to us, right? So they're Alaskans, and they should be known to us as an integrated health system. They are known to us, and this technology is really going to help us, the behavioral health system, move forward our goals of the right service to the right person at the right time, and generally the right time is now. So I had an experience pretty recently that I think is going to be different the next time it happens. We launched a partial hospitalization program, PHP. It's a new 1115 waiver service. All my friends from DBH, thank you very much for making this level of care available in Alaska and the decade of work it took to make that happen. And we're running those kinds of programs now. So we have a PHP program for folks kind of outside the behavioral health field. What a PHP is you get pretty comparable level of care in terms of intensity of service as you would in an inpatient stay. But you have a safe place to sleep at home at night. And you don't need to be in the hospital overnight. It's a very effective level of care. Sometimes prevents hospitalizations, can be an effective step down. Our child and adolescent PHP is taking off because we know there's a lot of Alaskan kids who don't have a safe place to stay, but most Alaskan kids actually do have a safe place to sleep tonight. But their family is like, we're at the edge, like we need a lot of help. So that's what a PHP is. And if you think about that level of care provided outside of a hospital setting, if you are in such a crisis that you need 5-6 hours of day treatment, and really comparable to hospital level care, when do you need that? A month from now? A week from now? 2 days from now? No, you need it now, right? But we're an outpatient clinic, right? So how does that work? So I recently did an assessment for someone who was referred to us by one of our partners here in town, and the client clearly needed this level of care. And they showed up at our clinic at 4 p.m. at night. Our PHP wraps up early afternoon. And so we're like, we've got to get this client, who's a brand new client to us, assessed, evaluated. I did an assessment. Our chief medical officer who also does clinical care, I walked the client down the hallway, did a psychiatric evaluation. You're in our PHP tomorrow at 8 a.m. We're looking forward to serving you. But with an HIE, right, we have such a head start on that process, right? This patient was referred to us by an organization that participates in the HIE. So tomorrow when I do that evaluation at 4 p.m. on a Thursday, the client's going to show up at our PHP, right? They're not a new patient to us, even though they're a new patient to the organization that I work for. So I'm really excited about access. Access is a huge issue across healthcare. It is a crisis in behavioral health, and this is really going to help us move that forward.
Awesome, thank you for sharing that. And Lori yesterday, so everyone, I'm from Atlanta. I ate a lot of fried food because I live in Atlanta, and Lori knew that, so she took me to get some fried fish yesterday. And over lunch, she was talking to me about another cool use case, to use that parlance, that her team is working on. That's closing gaps in care, identifying and closing gaps in care. I thought that'd be really cool to share here because I know a lot of you probably are involved in that work. I was trash talking claims data a little bit. She was trying to be cool about it. But we were talking about how much more useful the HIE is for doing that work quickly and effectively and accurately. So I'd love if you could share some of that.
So yes, part of what Envoy also does is we participate in value-based care contracts with payers. And the only thing we have supposedly is claims data. And most recently, we took the claims data that we received, for example, well visits between the ages of newborn to 21. And we took that claims data and worked with Latouche, as a matter of fact. And lo and behold, many gaps in care had already been closed. And so the performance not only showed that we were doing better than the claims data showed, it also showed us what patients still needed to be seen, but we knew who had been seen. So I do try to be positive about claims data, but real-time data is most important. And again, the HIE is how we check claims data. We sort of did a gut check and found out, oh, we can't necessarily rely on it a lot, ever.
I just don't like trash talk with other people, but I appreciate that. So the other thing I wanted to comment on, Lori, is you talked about the referral tool that Healthy Connect is able to spin really quickly to support the quit line. Are there plans to expand that to other different clinical cases and clinical programs?
Especially now that we've sort of learned how to do this by placing an order, which again is such standard work within any EMR. Absolutely. I mean, if you can think of it, we can probably do it. Definitely I want, and I hope that we can expand this referral process to the quit line across all of our practices. Again, because half of it's built, we just have to, it really is, I think the HIE said, easy peasy, we can do this. So, yes, but I think there's a ton of other opportunities with referrals, right? So I think it's unending in terms of what we can possibly do with it, right there.
Yeah, absolutely.
How long would that take?
So if you know EMRs, some of them are wonderful and some of them like to drag their feet. And sometimes it takes 4 months to get a project manager to even get the project off the ground. But again, that's where the HIE is very helpful, because if there's an EMR out there, they have probably worked with it. And sometimes it's relationships, is that they know who they can get to within that vendors, and we try to make it work. It's a simple process and not a lot of work on the EHR end. So to answer your question, it could be anywhere from 3 weeks to 3 months. I do like to push vendors and EMRs as much as we can. It is a personal joy I have.
Healthy Connect team, do you want to commit to that 3-week timeline? Right here? No, okay.
Oh, come on.
Do it later.
Harlan, you can do anything.
So back on track. Back on the bus. So Dr. Quinn, so you have many, many titles, but one of your titles is a medical director of quality and population health at Alaska Heart. So you talked about the vaccine hesitancy work that you and your team are doing associated with the HIE. What are other interesting programs that you've been able to facilitate more effectively with being part of the HIE?
Yeah, the vaccine program, we actually also were the first site for the more watered down version of the tobacco quit line. I should call it more watered down because it was actually incredibly successful with electronic referrals, except that when we click that button, it looks like it's an electronic referral, and it's kind of like when you open your computer and there's like a little hamster running in it. It actually just like created a flag that I had a staff member then taking it into a fax. So this will actually save me or save us a huge amount of time. What we'd really like to, what I'd really like to push into is cancer prevention screening. I think that's a huge one. That's something where a referral or referral process can be really helpful, and where otherwise a patient for many cancers actually has to touch multiple different providers, right? If they may see their primary care doctor or somebody else in the community and know that they take colorectal cancer screening or another type of cancer screening, it's probably a different person that's actually doing that screening. It may be a different person that, if that screening is positive, that they get more workup. Maybe a different person if they need a colectomy or a surgery, that would be a colorectal surgeon. They may need, depending on the cancer, not colon, but rectal cancer does require radiation oncology, and radiation, therapy. So all of these types of things, there is a care process with that. And from my standpoint, I think that that's a great spot to be talking about protocols.
Fantastic, nicely done. Oh, I guess we're taking questions already.
I'm sorry, is this time for questions? or
It
should I
can
wait?
be.
So for the referral process, if you are connected with Healthy Connect, does the other person need to be connected or just like, do both parties have to be connected to Healthy Connect to get this referral?
So, what if you go for
So to be clear, the things that we just talked about are potential projects, so none of that exists, right?
Right.
It would be what, you could create a process in whatever way you wanted. I guess it would depend upon, your institution, what you wanted. And some of that is certainly customizable, but, we'd have to
So we
talk
could-
later about what
Okay,
well, not me, I don't sell anything. I'm just a-
Absolutely.
Okay. you wrote my question down before I forget.
Yes, they both would need to be connected.
Yeah, oh, certainly, yeah, and certainly you wouldn't be able to create a referral to someone that wasn't.
I was just thinking in my head that if I had it and I had an order and I'm gonna make this referral, would it be like there's a fax machine for the other person? Like they wouldn't have to be connected and I would send this and it would fax to them electronically from my.
Can do electronic fax, I don't know that it, I guess I'm not able to, I think it would depend upon the situation. There's
Okay.
just a lot of variables in that for me to be able to answer, and I'm not the technology person.
That's
I'm
okay.
just
He
the-
said I could ask him. Right?
The great news is though, the HIE to Optum, which is the state's organization that helps with quitline, that's done, that's built. So if you are indeed connected to the HIE and you are capable of placing an order like an X-ray, and you have a vendor that is on top of their game and willing to work with you, you can make it work. Right? HIE team?
They gave a thumbs up. And for our virtual attendees, I apologize, we didn't pass the microphone. The question was, do both parties, all parties participating in that referral process need to be connected to the tool of the HIE? And the answer is yes. And so I apologize, you couldn't hear all those responses. One more question for me before we do general audience questions. And it is it's going to be a little different for Joshua, since you're newer to the HIE and just took that jump. For you, I know it's a little bit different how you and your team participate in the HIE right now. What is your wish list? What's your top three moving forward to participate more effectively and integrated with the HIE in the community?
Yeah, so we need to contribute to the HIE so that all the benefits that I talked about for us and our end for our patients are also experiencing when they show up in your health systems. So we are committed to that. Our executive team is committed to that. We want to be contributing to the HIE because the services we provide are very unique and often can be the key in terms of understanding our complex patients when they show up in our health systems. So that's a big piece. The second big piece for us, I don't know if this is a wish list or just an opportunity, is as a CCBHC, we're required to provide primary care. Most CCBHCs in the country do that through what's called a DCO, designated collaborative organization. We decided that we were going to build primary care inside of our clinics. We're not trying to, compete with your giant primary care clinics in the community. All we're trying to do is figure out who the client is, and this is a data question partly, who the clients are of ours, that even with the tightest referral system and the best coordination, when we send them even a mile across town to get primary care, they're not going to make it there. And that has nothing to do with your system and you not welcoming them and all those sorts of things. It's our most vulnerable and fragile clients that really were much more effective when we walked across the hall. So we have a very small, but very effective and essential game-changing primary care department within our organization for some of our clients for whom access is really a challenge. And for that team, this is gonna be a game changer. Because they're integrated in our system, so they know all about the complex mental health condition that then is interfacing with this general health condition. But they're not gonna be in the dark anymore, because now, as a primary care provider, they need the information for the broader health system that really informs the intervention they're providing. So that's two. Maybe ask another question, I'll come up with a third.
Okay.
We didn't script the question, so this is right off.
Now, I don't know if anyone can tell, but we are winging it over here. And I'm gonna end with Lori, because I know she is a huge advocate of the HIE and seems to do a lot of work recently, but Dr. Quinn, I know, we saw that beautiful slide you put up with all the amazing progress of the HIE in the past couple of years, and you know, really in the past year, a lot of really good participation and movement. So I know this is also a planted question from our last night conversation, but tell us why Alaska Heart jumped in to join the HIE, because it previously was resistant, from what I understand, several years ago to doing so.
Yeah, that's funny. I did say you could ask me that, but I wouldn't tell her what the answer was. It's more exciting. You know, Alaska Heart, the HA's been around for a long time. And Alaska Heart was honestly one of the big holdouts back maybe 5 years ago when I first, or 5 or 6 years ago when I first started. We got the pitch about we should join the Health Information Exchange. And at the time, the sentiment of the group was we already have all of the data that we need because we're a big institution, right? We have 300 employees, we have 30 doctors and another 38 PTs. Like, we actually have a medical records department. We're able to get all of that. And so we felt, well, our data is actually really valuable. It's more valuable to the Health Information Exchange than what they give back to us. Times change and thoughts change. And we, over the course of, for Alaska Heart, over the course of the last 5 years, started to think about how do we interact with the healthcare community? How are we part of strengthening the healthcare infrastructure and the healthcare system in Alaska? And so it's not about what the HIE does for us. It's about what we can do for our patients by contributing that data. And even more importantly, there's just so much potential with a health information exchange that was that health data utility that was able to coordinate care for a state with a fragmented healthcare system. In my opinion, not only do we have the opportunity, but we also have a responsibility to participate in that. If we can improve that, if we can lift that up, it is really important for us to do so. Everybody has their own institution. Everybody's institution can make their own decision on that. But for our institution, we decided we need to get behind these people. We need to join on. We don't want to be the last people to join on. And it's worked wonderfully. It's been a wonderful partnership, and we're so thankful to be a part of it. I'm thankful to be a part of it. Thank you, guys.
Awesome, and one more, and then we'll take questions. So Lori, what would Envoy be without the HIE? I know you talk often, advocate for how it's been able to help you really get this thing up and running.
We literally could not function without it. If we hadn't gone with the HIE, we would have literally had to create our own HIE and just have it just be our data of our practices. But the great news is because we worked with HIE, not only can the practices within Envoy work around collaboration and patient care, practices outside of our network can also access this information. So if we didn't have the HIE, we'd have to spend a whole lot of money to build it anyway, because we can't function without data sharing.
That would not be fun. All right,
And expensive.
that's right. So thank you to our panelists. We're going to take questions now for the next 10 minutes or so, if anyone has them. And if you do have a question, you need to pass that mic around so our virtual attendants can hear. Is that right, Bill?
It would be really
Or
handy.
if you could just come on
Come to the
up,
mic.
come on up. I saw you. Yep.
Okay, so, yeah. Better for my son. So recently I was with an agency that was curious about the HIE that didn't have any staff that could really devote their time to work on that kind of project. And just working, this was in behavioral health, so we were doing mandatory reporting to ACAMS. And just trying to get our EHR to interface with AKAs was an unsuccessful 3-year project. There was a lot of staff time in a small nonprofit being devoted to this thing that couldn't happen. I know that the AKAs was up for a contract renewal, and I was wondering if these considerations are part of that contract process. And also wondering just, how do you know what's a good EHR or EMR that's actually going to be able to integrate these systems? Thank you.
I'll be honest, I don't work for the state, I don't know as much about AKAs. I know that, Georgiana is a parallel system, and I actually, I don't know much about AKAs, so I won't be able to say anything about that.
I don't really say either, but I did know about that. So I was in there this morning. So I appreciate the question of like, well, we had this experience here. They're just different. They're different. I encourage you to think about it. I do a lot of work in our AKA system. Our team does. I'm part of it. And this is really a kind of a different system. So I'll just say that I would kind of it's a different system. And for us, we think about our interface with these two systems a little bit differently. So I would just give you a little bit of a pep talk. If you say, well, we tried a data integration system here and it was challenging situation, I would just encourage you to approach the HIE with just kind of from a fresh start. That's my word.
Yeah, and I'll add on to that we've all been burned by electronic medical record of some sort or some sort of tech. I've always stayed away from tech because of that, but not anymore. So get back on the horse. And the other good thing is that the health information exchange team is used to that. With some of the ongoing practices are one provider shops, and they obviously don't have the resources to spend to integrate something. That's actually why we have outreach specialists that are both PAs, right? So Mary and Carlin will come to your practice, talk to you. We try to make it so much that it's really not much of a lift on your stamp on your institution, other than you do have to be the one that puts in the ticket with your EMR. But you'd be surprised how many EMRs can work with this. Varying functionality, but so it may not always be that easy button if you have Acme EMR. But that said, you get a lot of functionality out of it. So I would encourage you to contact us and see how it would work. And we'll try and make sure that there's as little it's as little work for you as possible.
Let's take another in-person question and then I'll read off a virtual question.
Yeah, so we definitely talked about this in the last question a little bit, but I'm curious to know what are some of the barriers you've noticed with getting folks connected to the HIE?
Is that mine?
Lori Roy created interfaces with 31 different practices. So maybe she's the one that knows.
There are a couple of things to take into consideration. The ability of the EMRs to vary. Cloud-based versus server. I mean, there's a lot of things that come into that. So I would say the barriers oftentimes can be the EMRs themselves. But again, we've worked with enough of them now that we realized the initial barriers and we've been able to work through them. And if we make the process easy, we want to make it as easy as possible to our practices. Again, the heavy lifting needs to be done by us.
And that functionality, you may or may not be able to, if you have the worst possible EMR in the world, which sometimes feels like all of them, but if you have that one, you may not be able to contribute data through it, but you may actually be, or you can still get access. So you can still have the web-based portal through CRISP, so you can still at least see patient data so that you can take care of the patient. So.
Can I help answer that question? So primarily what you want to look at is your.
Can you stand at the mic?
Yeah, so I can help answer that question. So part of what you want to look at, your main focus should be on your transport. Most EMRs, EHRs can export to a CSV file, They can export to a database, they don't have to have an HL7 transport, but that helps. So as long as your EMR, EHR has some way to export that data, then it can be imported into the HI. Either through a manual process, SFTP, or some other method.
It's great, thank you.
Perfect.
I'm gonna read a virtual question quick. I apologize for making you stand a little bit more here. It's from Haley Spencer. She says, I'm curious about the functionality of the HIE in relation to chart notes. If no referral is made, would all chart notes be accessible through the HIE to the outside providers? Could they interface into other systems if a care team is created? I wonder about behavioral chart notes being accessed by outside providers that may or may not need to know that sensitive information. Joshua, that might be for you.
The first part's pretty technical, so that's.
Harlan's actually the one that's good at this.
But Carolyn,
But the point of, or
Give her my email.
that, so, behavioral health information is, Carlin, you just correct me or raise your hand if I screw this up, okay? Behavioral health information is treated differently, than medical information. Medical information is an opt-out. Behavioral health information, for a patient is opt-in. So you actually have to opt in and say that you would want to share those with your providers. As well.
Can't.
Oh, my bad. Oh,
Dr. Quinn, let's make it pretty simple. So I think we should leave it with the first statement. So behavioral health, I'm Carlin. Hi, all in the back. Behavioral health information is housed in an entirely different consent protected repository. And if I'm starting to say technical words, just stop me. And so we're really careful and respectful of the way that the community wants to view and have access provided to behavioral health information. It's really a talk in and of itself. And so I would be happy to go into further detail with anybody. But just know that we take that very seriously, and that in order to view and share access to that behavioral health information, the patient has to actually opt in and say that they consent to do that.
Thank you very much, Carolyn. Next up.
Hi, I actually have two questions at the first time. Is there any concern about conflicting data when it comes into the HIE? If you have two sources that have differentiating information? Say immunization, the data is different on two immunizations. Does it clarify between the systems, especially if they're bidirectional?
I'll be honest, I'm just a doctor, so I do know that there are algorithms and there are ways to make sure that health information exchange has the most truth. And so there's a process for that. That's how I would say that. And I'm sure that somebody from the tech team is going to be helping me. Are you helping, Carlin?
So the question was, let's say two immunizations come to the HIE and they're conflicting, like different name, or maybe it says monkeypox, we thought they got vaccinated for COVID. What does the HIE do to make that judgment call, or what's that process for the data quality? There's a lot of smart technology that automates that, and there's also a really strong MPI, which is the patient match, so that we can take the demographics, and we have a very strict matching policy. And so occasionally, as you all begin to use the HIE, you will see two patients display because they didn't have enough demographic points to actually merge them. And so we have a lot of strict matching criteria. If there's discrepancies in the data, of course, it's always important for you to contact us. We display what people send. But as far as the patient match goes, yeah, we've had a lot of talk, and we're happy to take input if people are seeing concerns, but we have great data and don't know what else to say.
I would just say that it's probably not a lot different than EMR that you can put that data in, except that there are that many more checks and balances, that many more people working on making sure the data integrity is good, and that's and that the health information exchange has is the source of truth.
As a follow-up, the way I kind of see this in my head, it makes sense to me, and maybe I'm completely off, but is there any aspiration to turn this into into potentially a patient portal as well?
Somebody else want to tell
Craig
the
might be
story
able to
about the
answer
patient
that.
portal?
Someone give this man a mic. This is Craig Bem, he's the CEO of CRISP, which is the technology vendor for Health Connect.
So, hi everyone. So for patient portal, there are a couple of just key things to remember. One is that patients have a right to access their healthcare information. HIEs are required to make that access available. And so we're working really hard to make the technology make that access available. The second piece is that the HIE is most likely not the best place for patients to access their data. It would be much better if they went to their primary care physician, their health system, the physician that can actually refill prescriptions, schedule appointments, and do all the things that one would want to do when they interact with the electronic chart. And then the third point is that as patients access their data, if they do that through third-party applications, like you use your phone and you say, like, yeah, go ahead and get my records from Healthy Connect. I personally have some concerns with the state of that industry and whether patients might be accidentally giving up too many rights to their healthcare information without reading those long end user agreements. So the long and short of it is, yes, there is ultimately a plan to give access to patients. It's shockingly difficult. And in the meantime, I think, I don't want to speak for the Healthy Connect team, but I think the more we can get data interoperable through the HIE into the electronic medical records, that's probably the better place for patients to go.
And I think we have time for one more question before Brittany's mandatory 10-minute break.
Thank you. I'm curious about what goals there are, what exists in terms of incorporating like social determinants of health data.
I need to get Craig back up here. All right, Craig back.
The answer is yes. How that's done is a technical thing that this wonderful technical person will tell you.
Okay, I will try and do this very briefly. The very short answer is yes. It's incredibly important that a patient, a citizen, a person, right, has all the things that impact their health that's relevant and appropriate to flow for all the people that impact their health, which clearly includes non-healthcare events. That said, one of the benefits of having the local governance and Healthy Connect and the partnerships with state agencies is that all the different data use rules, all the different types of creators of non-healthcare information vary dramatically across states and even within states. The technology, as we think about data, the technology can kind of do all of this already. So getting a clinical chart is very similar to getting an assessment that was done and can be normalized to understand some of those transportation-related issues, is at risk for losing housing, other things. And matching the patient through the healthcare matching algorithms also works, whether the data comes from a non-healthcare setting or a healthcare setting. So there are some nuanced challenges like getting authorizations for the data to flow appropriately. Matching patients if you're unhoused, having an address to match a patient is very difficult, obviously. So there are things to work through. But I would say that the HIE infrastructure can and does support non-healthcare related information. I would encourage everyone in this room to think through what are the best sources for that information, whether they're community-based organizations, whether they're state agencies, whether they're submitted through some other channel, and prioritize them and work with the team to try and drive that.
Awesome, and Joshua here has something to add on that as well.
Yeah, so there are special considerations having behavioral health involved in these kinds of systems, but if you want to do that, you gotta have us. Social determinants of health is what we do. So thanks for the question. And we've got to be committed to be part of this. So I realize there's a lot of special considerations, but if you want to move forward, social determinants of health, you have to have behavioral health systems involved. So thank you.
Awesome, thank you so much. I think we are at time. So we are on a 10-minute break, and please clap for Dr. Quinn especially.
They have contact information.
care. Again, we appreciate you all for being here, and we are going to get started.
Awesome. Thank you so much. It's so great to see everyone here. It's fun to catch up and see people in person in so many ways. I am Dr. Ansley. I'm the Chief Medical Officer for the state of Alaska, and I'm going to be helping to coordinate this panel. I learned long ago never to follow CAT, but somehow that did not work out in this space. So we're going to do our best and kind of go with it in how we move forward. A couple just little details, you know, there's a lot of people, it's really great to see actually a lot of state people here. I'm just gonna give them a shout out. So, you know, we got like Renee from Medicaid back there, Laura Russell, who's here, which is great. Mariah Shakespeare, who helps to run our IT system space. So, you know, I'm getting a lot of questions like, where's that RFP at? Or what's behavioral health thinking about this? So our team is here listening and happy to kind of help respond in that space. So I just wanted to give them a shout out in the back as well, because I think that's incredibly important. And then I also want to just give a special shout out to Commissioner Kobal. This next presentation and kind of panel discussion is really about patients. And I really appreciated Dr. Quinn kind of saying at the end, you know, this isn't just about what our system does, but what's right for people. And I think it's really easy to get into policy space and it's easy to get provider space and start to strong arm each other and be like, this is my role and this is my role. And people fall out of that system. And we've got amazing ways to try to think about that space, but we continue to find people that the system doesn't serve them, and instead they're trying to battle the system in all sorts of ways. And so that's why this next panel presentation is really thinking about complex patients. I oftentimes get the question, well, what do you mean by complex patients? I have this program that does complex patients for this. I have this high utilizer program. I have this, I have that. And there's a lot of great stuff out there. We've been doing a deep dive within Department of Health in combination with DFCS on what does complex patients mean, how are we doing it, and what does that look like? And essentially how we're defining it right now is a patient that no one system is meeting the needs of. So pretty easily in that sense. And we're creating kind of 3 different buckets of how we address that. And the first and the most important is that very individual level. So who is that person and what do they need? And really being able to be referred in from any one division. So the division's like, this person needs things from outside of my division, and I need help figuring out what that looks like. And oftentimes we see one division will be working really hard on something, and then they realize they need something else from another division. And it can be a pretty incredible period of time before that fully gets recognized in the other division gets brought in. We've got Travis here from OCS. We've got like all these different people thinking about these people from different perspectives. So that individual kind of multidisciplinary team, who's on first, how are we helping to support the needs of this person, both from a clinical aspect, who are our partners in the community, who's their healthcare provider, who's their behavioral health provider, who's the public health nurse who's involved in this case, who's their OCS worker, who needs to be part of that. The second big kind of component is what are we doing within state government to change the systems, not just based on an N of 1, but an N of 10 or an N of whatever. Because a lot of times we'll get a lot of advocacy, like we need to make this new really awesome widget. And that new awesome widget may be the way that we really need to go, but we want to make sure that we're making data-informed decisions to be able to do that. So what data do we have? What ways can we use the HIE and other data sources to be able to input that, as well as these individual cases and what we've learned from them to make sure that we're able to change, you know, rates, the way that 1115 works, all of these like big structures that are really important, but take an impressive amount of energy to change. You know, I was on a panel yesterday with Emily Ricci, DC commissioner over Medicaid, and you know, we said like everyone says like Medicaid, why don't you? Why don't you X, Y, or Z? And there's so many components to that. And so making sure that we're really mindful about the ways that we change our systems prior to changing. And then the third big component of it is thinking about specifically how do we engage with outside stakeholders and how does that partner together to make sure that we're having that real-time input. And it isn't like a hierarchy, it's like a circular, you know, conversation. And how do all 3 of those input and influence each other so that we can better meet our mission, which is to improve the health and well-being of the people we serve. That is the goal of all of this. So with that, I really appreciate this very diverse panel. And what we're going to talk about a little bit is about complex patients and how we can use information technology, data to help us. So we're going to spend the first 20 to 30 minutes just having each one of them go down the line and tell us a little bit about themselves, why they're here, and their thoughts and perspectives on kind of complex care and how that's working. And then we just have a series of case presentations that we're gonna have them reflect on and how their systems are or are not working. Again, to kind of bring that patient-centered focus back to what we're doing and think about how does this really look on an individual level, and then how can we think about the gaps in systems. So with that, I'm gonna start handing the microphone down.
Thank you. Good morning. My name is Eric Milligan. I'm the Chief Program Officer for Catholic Social Services. We're an Anchorage-based social services provider working to compassionately serve the poor and those in need, strengthen individuals and families, and advocate for social justice. We really spend a lot of our time working on social determinants of health, primarily with people experiencing homelessness in our community, but also with other populations like refugees and some others. I think a component of the reason that we're here is the work that we've been doing interfacing with our healthcare systems. So two of our longstanding programs, Brother Francis Shelter, partners with South Central Foundation to have a primary care facility within the shelter. Covenant House is also in that space where they're able to provide care within their shelter facility to kind of reduce some of those barriers to accessible care for a population that needs it. And then we also have a medical respite program within the shelter that is funded by our hospital systems, that takes referrals from our hospital systems for individuals with acute medical conditions that don't need to be in acute care, but need time and space to recover. So they'll come with some discharge instructions. We have medical case management in the facility. They don't need the level of care that a hospital can provide. Maybe they need to go to some outpatient rehabilitation treatment over a period of time until they can be released from that program. And then we also recently opened a complex care facility, our complex care shelter at 303 East Fireweed. It's a public-private partnership. We had a lot of support from the community, from Widener, a lot of our native corporations, from healthcare support, from the state and from the municipality. And it's serving individuals who are experiencing homelessness, who also have chronic health conditions, where we're able to help them stabilize in housing. We're able to provide wraparound services, transportation, to medical appointments, help them navigate the healthcare system, and kind of provide those back-end supports to address the social determinants of health so that they're able to meet their healthcare needs of the community. And then that facility's been full pretty much straight since we opened it. And we're really looking forward to see kind of some of the impacts on the system and care utilization that we're able to gain that data.
I'll just use Eric's. Okay, good morning. My name is Shelley Grigsby. I am with the state of Alaska, Department of Health, specifically chronic disease prevention in the Health Systems Collaboration Unit. So our unit is specifically working with how do we approach things at a system level, right? It's chronic disease prevention, and we know that we're trying to get people in for cancer screening, and we're working on monitoring their heart disease, reducing all of their barriers to access. And in my background, I started with cancer screenings where we worked with over 200 providers who we actually paid for the service for women who were lower uninsured to receive care. And what I got out of that was our billing system is so broken. It's so broken. And so we would have a free service for these women and they're still billed and they don't understand how to read the Did I break?
Nope. Okay.
They don't understand how to read the explanation of benefit. They don't know who to talk to. They have trouble getting to and from appointments. Appointments are never really on time for them. And so when we're asking people to prioritize prevention, that's really hard, but you have people with real issues, right? When you're seeing, because you do have diabetes, how are we going to incorporate the prevention activities so that the patient has time and that the providers can do this when they're still triaging real issues? So I've had the pleasure of working with Dr. Brennan and with the tobacco program specifically, where we looked at how do we enhance the quit line so that it can be utilized better. And what we did find is if a provider will say, to try this resource, and it's a seamless process where they're not getting, here's a card, call the quit line, or bombarded by a bunch of different calls from a bunch of different locations. patients actually used it more. And then we were actually, we were seeing more progress in that area. We'd like to expand that into other programs like diabetes prevention programs, self-monitored blood pressure, all of those evidence-based resources that the state invests in are available, but we need a way so that patients can access them without too much more trouble than they're already having. Leave it at that.
Hello, I'm Christine Hunley. I'm the program director for the High Utilizer Master Program with Links Resource Center. Our program was designed after a community health needs assessment performed in 2013 identified that the five top priorities for the community were all behavioral health related. Our program is grant funded by the Mass Health Foundation and the Alaska Mental Health Trust. We have a local emergency department physician, Tom Quimby, who serves as our medical director. We currently have 3 community health workers to provide case management with plans to add 4 in the very near future. The HUMS program was developed to help individuals with access to appropriate resources and consideration of alternatives of care for those that frequent the Madison Regional Emergency Department. This cohort of individuals often are also high utilizers of law enforcement, EMS, the community's first responder system. They also really struggle with traditional case management. So what we do, doesn't matter why they go to the emergency department, we work with them to bridge the gaps in care, either by supporting lifestyle changes or improving access to community resources. Staff meets individuals where they're at in the community to help people with complex needs receive person-centered care and to achieve improved health and well-being. We provide referrals to primary care providers, behavioral health providers, other specialties. We provide and arrange transportation to medical appointments, accompany them to their appointments if they need that. We provide temporary transitional housing through hotels, application assistance, resources for mail services, it's hard to do anything without an address. We provide temporary cell phones are provided to our clients so that they can be successful. They have to have a way to communicate, a way to schedule their appointments, a way to see if their cab is running late. If they're gonna meet the cab somewhere because they're homeless, they need to have a way to know where they're at. We also provide for like basic needs, food, clothing, hygiene products. We do copay assistance. We help them get birth certificates, social security cards, driver's license, photo ID. We utilize the collective medical or EID to confirm eligibility and monitor clients' emergency department use. We receive notifications that a HUMS client has gone to an ER across the state and in some other states like New Jersey, Texas, Florida, California, Washington, and Oregon, just to name a few. We use this up to reach out to the client, identify the reason they use the emergency system, and work on communicating with them and coaching them on more appropriate use of the emergency system and what's the best use for their condition. Collective medical also allows us to monitor program success, which continues to improve the longer they remain engaged. In 2021, which was year 4 of the program, the ED utilization overall reduction was 36.1% and continues to decrease to 53.9% after enrollment in 2 years. Within collective medical, we're able to create care guidelines documenting the client's current healthcare providers, pertinent medical history, and notifying other users that the client is engaged with the HUMS program. We also provide contact information for the assigned community health worker. We use Salesforce to collect our referrals, client data, and to document our interactions and goals the client wants to achieve. During intake, we complete a needs assessment, and that's repeated every 6 months. We're able to show the client the success that they've made by giving them like actionable data. A multidisciplinary team comprised of a physician, case management organizations, mental health providers, therapeutic courts, organizations that provide treatment for substance use disorder was developed just prior to HUMS beginning. The facilitation was passed to Connect Matsu, a program of Matsu Health Foundation in February 2022. This team is an integral part of the success of the HUMS program. We're planning to use the Cloud9 application as a secure way to communicate within the group outside of our once per month meeting. We will be able to meet with the client over the app, conference in all necessary providers. The app will allow an MDT care plan to be created. So all of the MDT engage with that client can work collaboratively, and we can, to help the client meet their goals, and we can help decrease duplication of services. Cost increase, the healthcare and general workforce drought, technology expansion to add for more effective case management, all kind of increase the burden on our funders. In year 4, 81.1% of our clients had Medicaid coverage. And we were able to show an overall cost savings of $7,251,590, which was an improvement over the previous year of $4,773,808. This is clients that had a reduction in emergency department use, and it factors in the cost to run the HUMS program. We're unable to bill for our services because we don't have a clinician and we're not accredited. By adding these to our program, it would just duplicate other services that were around. It would decrease our ability to use creative strategies to help clients. There were other largest client expenses, transportation. We don't have a transportation system in the valley, and so those clients, we pay cabs to get to all of their appointments. They consumed our entire 2022 budget for client expenses. Because we're not considered a Medicaid provider, we're not able to request transportation authorization through Medicaid to healthcare providers. That would help. If we were able to do that as a case management organization, that would also help us change our budget a little bit. Thank you.
This will work. How about now?
Real close.
All right. We good? All right. Well, good morning. My name is Jason Ball, and I am the Medicaid Quality Assurance Manager at the Division of Healthcare Services at the Department of Health. And so I have the privilege of really standing at the intersection of data and intervention in my role at Medicaid. And so what that looks like is we have access to all of the claims data and all of the claims data for our entire Medicaid population, north of 270,000 patients, our neighbors, our friends, our coworkers, our colleagues. What we have the ability to do in the QA unit, the healthcare services, is create data profiles on behalf of our entire patient population. So we create profiles using tools. We are looking at pharmacy use. We're looking at the intersection between harmful drugs and therapeutic classes that are contraindicated with one another. We are looking at new patient visits, who's popping around to different new patient facilities, looking at things of that nature. Again, we're looking at emergency department use. Beyond what we can see through claims data and stuff that we've been billed for, one of the other things that we can do in relationship to these data points is look for the absence of certain behavior patterns. We're looking for the absence of primary care visits. We're looking for the absence of certain medications when we see that by diagnosis, that by procedure code, that by imaging, that other data points would point us to the fact that this patient population should probably be on a certain prescription regimen or have access to some of these other kinds of things. So we're also looking at the lack of care. Getting into then the intervention part is, so we have the data, what do we do with it? And so there's really two different programs that are accountable for me at Healthcare Services that try to get at that for really just a fraction of a % of the population of the Medicaid program. So we manage just under 1,000 people in what we would call our care management program. That program is designed to partner with primary care providers, to establish an official partnership between the state of Alaska, a primary care provider and facility, and a pharmacy, and get everyone talking and on the same page in an official capacity so that we can coordinate care. One of the things that we see most often is disconnected care, that no one's really in the driver's seat when it comes to patient care. And so we want to make sure that we empower those relationships on an official level to make sure that folks are empowered to talk to one another and that someone is actually responsible for the patient. So again, we're doing that for about 750 patients. Beyond that, we are looking, we have a much smaller population in our Alaska Medicaid Coordinated Care Initiative, AMCCI, and that provides a case manager that helps not only tackle some of the medical things that we were just describing, but also then gets a little bit into the social determinants of health, looking at food stability, looking at housing, looking at transportation, some of the other things that come with a lack of continuity of care and things of that nature. So those are a couple of programs that we're really excited about as it relates to serving the complex care population. Something that is on the horizon for us that we're really excited to partner is in relationship to the health information exchange. We're exploring different ways to make sure that we are a better partner to the providers that are serving our patients in this capacity. So making sure that we get panels and alerts set up to make sure that our providers know, that those official relationships exist. Because the last thing we want to do is assign a patient to somebody who goes, they're not mine. And so, we want to coordinate that better. We want to be a better partner in that regard. One of the other things, as it relates to some of the alert functionalities and some of the other things that we're looking forward to is because our data is claims data, there's a lag there. There is a disconnect between the time of care and ultimately when we pay the bill for that service. And so some of these alerts and some of the interchanges and data exchanges connected to the AHIE is going to make us a better partner. It's going to help us serve our patients better by getting more real-time information as they present to the ED or other facilities that we can track that in closer to real time versus waiting 30, 45, 90 days for a bill to roll through. So we're excited about those things and look forward to continued discussion.
Hi, my name is April Resendiz. I'm the Quality Assurance, Quality Improvement and Informatics Nurse Consultant with the section of Public Health Nursing and with the state. And so we have 16 health centers around the state that have nurses who travel to or have a presence in more than 250 communities, providing safety net services at the individual level, but then also really focusing on that community and systems level. I'm trying to bring those partners together, getting people talking to see what are the gaps in our communities, where can we fill needs, and really what that looks like in every community is very different. But where our strength lies is in kind of that local presence, that familiar base, knowing the people there, working with, in some communities, it's the community health aides, and others it's the tribal police, or maybe in the community it's just the mayor because they're everything. So really just that local presence, getting to know the people, working with the schools for those safety net services. Right now, all of our coordination is by fax machine and phone, and so we're really looking at how can we improve how we're getting stuff into a health record and using different technologies to kind of better leverage, especially now. One of the things we've been leaning on more with workforce shortages and things, we're relying more on kind of remote workforce, having people down in Southeast help cover some of the cases up in Bethel and things like that. And that's really helped us realize that we need more easily accessible by everybody that doesn't rely on waiting for someone to send something down, look through it, get it back. But even as we kind of leverage that remote workforce to help fill gaps, really doing that our local presence, knowing our communities, knowing the people there. Let's do that, and we don't do any kind of primary care or preventative and just that safety net. So we may have someone come in for an immunization and find that they don't have insurance and they need their, a lot of times we get, especially with immigrant populations or new to Alaska, to have established care, having been able to set up with insurance yet. And so really working with them to get them what we can provide, but then figuring out what their other needs are, who best in the community can help serve them, and trying to get them transitioned into that primary care service to fill their needs going forward, and identifying what other resources they need.
Awesome. Oh yeah, I still have the microphone. So it's great to have this team up here and you can see, and I know many of the people in this room are also just doing amazing coordination of work in all different ways, and what this looks like is very different in different places. We recently did this exercise within the state thinking about complex care, and the initial patient that I'm going to present here is actually one that we used in that group as well, and kind of talking through what does this person look like. And so what I'm going to do is I'm going to just read a patient description, and then Jason, I might start with you, kind of starting for a high level, like when he would get that data in, kind of what he's thinking about, how he would intervene, and then talk more state level, like what you're thinking about systems level, Cheryl, like how the space, and then getting down to the programmatic, like, do you know this patient? How are you going? Which facts did you send about that? And what are some of those barriers, with the hope of identifying kind of from these different perspectives, what are levers that would help them and what are levers that are barriers, particularly in the IT space, to being able to get the care that needs to happen for an individual patient. And we have a series of questions and kind of different patients out here. We'll go through at least this one. We'll see how much time we have for additional one. And I also want to make sure there's a little bit of time for questions as well from the audience. So this first patient is a middle-aged man with a long history of being dialysis dependent, secondary to an autoimmune disease. He lives alone, he oftentimes falls and breaks his bones. He very much likes to be independent, but struggles to live independently. He intermittently becomes opioid addicted secondary to isolation and multiple medical procedures, broken bones, and depression. He intermittently becomes suicidal and depressed given the progressive as his diagnosis, but is too medically complex for inpatient psychiatric care, as well as physically unable to get to outpatient behavioral health resources. The combination results in more than 200 emergency visits, but I can tell you there's been patients with up to more than 400 emergency visits in 1 year, in just 1 year, with multiple EMS transports. This patient is triple insured, she has multiple insurances. He does not believe that he has a case manager. However, on a deeper dive, 6 different providers said that they are his case manager, yet none are aware of each other. So Jason, help us out.
That's a lot. So from our perspective, as we would approach a patient like this, as we would approach, just starting to unpack a lot of what we would see on paper as a referral like this would come in. Some of the very first things that we're going to do is we're going to be looking at all the pieces, parts, and players of the equation and looking for overlaps, looking for duplication, looking for who a patient like this is seeing most frequently, and trying to then make connections, make records requests, and really try to get our hands around the who's most frequent, who's most in charge of a situation like this. We're also going to work on trying to untangle that case management web that seems to exist, and make sure that we have coordinated with folks and make sure that we identify those who are going to kind of become that care team for this person moving forward. And so we're going to do some of that. We're also going to look to our clinical team at the Medicaid program in regards to some of the medication and some of the other things, looking at overlaps and duplication in that regard. And then we're going to be working with our partners at behavioral health, making sure that we're on the same page as far as services like that go. We're probably going to do a lot of that in the background using some of our surveillance utilization review functionality and ability to try to get that as tight as possible, and then working on having some of those conversations with the patient themselves, making sure that there's a clear understanding that this is coming from a position of advocacy, this is coming from a position of helpfulness, this isn't about dollars, this is really about care and about delivering quality and efficient care. And so that's how we would approach some of those kind of things. And then we would lay out a plan in regards to, hey, let's not try to tackle this all at once. Certainly time is of the essence, but let's work on some meaningful intermittent things that we can take that is at the right pace and comfort level of the practitioners involved that have been involved in this care team, as well as then with the patient. Say, let's try to take these meaningful steps, as we approach your care, and really come at it from that type of perspective is where we would start.
Yeah, I'm curious also, Shelley, from your perspective, like thinking about the system of care, what other kind of mechanisms or avenues are either barriers or successes that you see in being able to help support a patient like this?
Now is it on? Okay, so when I saw the scenario, my take on this is it's not that there aren't enough resources, it's not they're not coordinated. And so there's duplication going on here, which is gonna lead to more frustration for the patient, right? There's a lot of unknowns too. You said 3 insurances, so what are those insurances? Because they all have different rules around them. If the patient wants to be independent, is it a matter of, is there anxiety around going to doctor's visits, what they're being told? Transportation, we all have individual programs that help pay for that, but it's not coordinated in a way that if one program runs out of funds, do we know that there are others and where those are? So when we're talking about a patient like this, when I think about the individual clinics, they take a team approach on how to manage this patient. It'd be nice if we, as the state, all these data programs, everything, community-based organizations as well, could take that team-based approach, right? So we are looking at the data, we're trying to figure out entangling it, like Jason said, but who does take the lead? And right now, we don't have anybody to take the lead at all. Hopefully that's where the HIE can help us build some of these systems. I know the question was, including community-based organizations, we need them at the table. They're not currently reimbursed for a lot of the work they do, so they're struggling and it's not necessarily sustainable. But our individual programs who have the funds to do this need a way to funnel those funds so that we're all working together.
Yeah, no, I appreciate it. I think that emphasizing where there's funding is just coordinated. April, you're very much in the communities and thinking about this in the communities, you're looking at some of the data. Can you talked about your love of fax machines and Excel spreadsheets within public health nursing. Can you, thinking about this patient coming into a public health center, what tools would be helpful for you to help manage this patient? You work within the state with some of these other organizations, but then you're also working closely with the community partners and we'll turn to our community partners.
Yeah, I think kind of knowing what's in our communities, and really being able to connect them right away. I know, and some of those partnerships that were built up, I live in Juneau, and we were able to, over COVID, kind of start working really closely with our EMS, and now if we have someone like that who comes in and, or we become aware of and we want them to get services in the home, we can coordinate with EMS, we provide like, here's vaccine, and then the doctor provides, here's like some meds I need dropped off, and oh, they also need some Tylenol, and EMS can actually pick all of that up, go check on the person, do a wellness, drop all of that off, and that out of kind of that coordination, that need of the phone calls we were getting, people call us because they see like Thursday Department of Health, and kind of we'll call just looking for services that aren't really in the wheelhouse, but then knowing those community resources. And so for this individual, it would be, or just those relationships with who it's their local doctor and calling over to the doctor to find out and getting there, okay, like, hey, this person stopped by again, or we got a wellness check call on what can we connect with. And so just kind of having those local relationships allows us to connect, and then also trying to do the more formal community assessments. So getting those, and most often it is the local service providers who are easier to get in for those community assessments than maybe the state agencies and whatnot. And so bringing those community providers together to talk, so we all know who's providing what services. One of the things that over and over happens and then never quite gets finished is that like list of all the community resources, and by the time you finish it, it's changed again. And so instead of trying to make that list that you put in writing, just having those regular conversations and finding a way to pull everybody to come to the table on a regular basis and talk through what they're doing right now, where their gaps are, like they just lost their outreach coordinator and don't have that right now, so we can fill that gap in, and really trying to make that keep those conversations going so that we know right away who's got the resources at the moment.
Yeah, and I think, April, you hit a really good point of like, as soon as you make that list, it's then expired out of date. And that's where I think like really thinking about the HIE and what tools we have and resources. So if new providers come on, that's a part of the system. And then April can just, put in there, I need housing for this person, and then the housing resource comes up. I think we continue to use our Excel spreadsheets and relationships and phone calls because it's what we have. And how can we think about a future where we're different, where Jason is putting in the information on who's that #1 provider for that patient, and then April can see it when that patient shows up in their place, and she can access what resources are there in the community to be able to see it all in the same place, instead of right now what you're really hearing is kind of silos. But, Eric, you're doing this at a little bit larger scale. You've got medical patients and you've got behavioral health, you've got people who don't have housing. You're using some of these technology services. Maybe can you comment about you know, where you see the strengths in the IT system, the weaknesses, and where you want to see the future.
Yeah, so organizationally, I think one of our strengths is case management. And I think, you know, if this individual identified taking care of his medical needs is something that we wanted to work on as part of his care plan, that would be a focus. I think a potential couple failure modes on the social services side, we don't have access to the public health informatics. So we wouldn't know unless the patient knew about his 6 other case managers that are working at the dialysis center or whatever. So we'd be, to some extent, duplicating services there. But we could certainly spend time working on the social determinants of health, get housing, security, et cetera. If the individual is experiencing homelessness, we could bring them into our complex care facility and really have that on-site case management, people building that relationship of mutual trust and respect, arranging transportation, getting them to his appointments. But it still requires, in our system right now, or our programs right now, a reliable patient who's able to communicate his needs and ask for support to follow up.
Yeah, I appreciate that. And what you can and can't see is such a limitation. And I see Christine for last year for a couple different reasons. And the first of it is, we sent out a series of different cases to the group to say, which ones would resonate with you. And they all chose one, I think. They all said that this one was the first one that they wanted to start with. But I have to admit a conflict of interest before I turn it over to you. As many of you know, I'm a practicing emergency medicine physician, and patient one is literally a patient that I saw incredibly regularly, over 400 times a year in the emergency department, and then calls each of the different agencies on the table here at different points being like, hey, can't we do this better? And this isn't working out. And you're hearing a lot of the barriers on why it couldn't work out. So I ended up meeting with the Mount Soup Health Foundation, and we started the HUMS program because we couldn't figure out how to do it in any other way. And Christine has taken it on and taken it to a whole new level. So I know she's seen this type of patient. And I will turn it over to you about kind of this sort of patient, what you're seeing.
Yeah, this is kind of our tradition. All right, so this is our normal kind of patient we see day to day. We get probably about, in the last 3 years, we've gotten 274 referrals for clients, very similar to this. When they started the program, they identified there were about 500 clients that were considered high utilizers of the Mount Soup Regional Emergency Department. We currently have a caseload of about 88. What we do is we go out in the community, we meet people that don't want to get out of their house, can't get out of their house, haven't been engaged with healthcare, or their only engagement with the healthcare system is, oh, I need to go to the doctor, so they call 911. And they're gonna take me to the emergency room, and then someone's gonna pay for me to get home. And oh, my meds are running out, so I'm gonna go back. So what we do is we step in and with this kind of a client, we're gonna start by, identifying the providers that he's seeking care from. With his dialysis, making sure that he gets to his dialysis and home on a regular basis is super important. We're gonna go to his medical appointments with him if that's what he wants, because sometimes people get confused listening to medical jargon. And so we sit there, we can break it down, take notes for them, and provide that to them later. We would create a care plan in collective medical or EDIE. This will notify anytime that they go to the emergency department, they'll see that this client is working with the HUMS program. We can create a care guideline, letting them know who all the providers are. So if the client goes there for something related to dialysis, who's his nephrologist, who's he seeing, who's ordering the dialysis. So we put all those providers in there with contact information. We put the contact information for our community health workers that are assigned to that client in that same place, so they can call and say, hey, this person's back in the ER, what should we do with them? So we'll step in and try to figure out what the next steps would be, so we can minimize return trips to the emergency department. That's our ultimate goal, is reduce ED utilization. We would help him get assistance in the home. Looks like he falls a lot, so we're gonna check it. If he lets us in his home, we're gonna check it out. Is there anything that we can do to help minimize falls? Does he need PCA services or home health care? Does he have, maybe you can set him up with telehealth, behavioral health care. So while he can't go to an inpatient and he can't get out to go see behavioral health, let's figure out a resource to get it into the house. We'll provide him with a phone so he can do telemedicine appointments.
Make sure he has all of the, like I said, the medical appointments, he can, we're gonna get him there. We're gonna meet him there, and we are a patient-centered program, so we wanna make sure that what we're doing is what they tell us to do. Sometimes we'll start with one step to meet, does that seem like the most priority? Nope, but if we can get the steps that they feel are the priority, then we'll eventually get to what I thought was important. Very, very imperative to make sure that the client is more than just along for the ride, like they're directing where we go. We're gonna reach out to all of those healthcare providers. We're gonna let them know that we're involved. We're gonna tell them what services we offer, and we're gonna make sure that if the client allows us to, we'll be their main point of contact. We'll schedule their medical appointments for them. We'll make sure their ride shows up when it's supposed to show up. We're working on a pilot project with Valley Charities right now with some notifications to identify if, where the cab is, kind of like Uber. We also have an Uber Health app. So we just don't have a lot of Uber drivers in the Valley. It's a great concept. We have enough drivers. But that's basically, we just walk with them hand in hand where they want us to go to make sure that the use, we don't tell them by any means not to go to the ER. But we do coach them after an ER trip, about medical necessity and is that the best use of emergency services? And sometimes they'll say, no, it wasn't. I was just kind of panicked. Or sometimes they just don't care. And those are the hardest ones to get through, but we still offer them support. Once you're enrolled in the HUMS program, we don't have a cutoff. We will continue to provide support. If we get someone through treatment, they're in their recovery and they struggle, they call us back, we're right back in, right where they pick up right where they want us to.
Yeah, so I appreciate that kind of emphasis in the work that you guys do in that kind of grounds, patient level work. There's a couple things that you refer to that I just want to bring back, and I feel bad stealing a little bit of Carrie's thunder from later today, but I got to see her notes for the closing, so I'm really stealing the thunder. But they were brilliant, and but she really talked about reusing, and she'll really emphasize it much better later. So we're talking you bring up EDIE, a lot of people are like, well, what is that, or what's collective, or all of these kind of things. So during Medicaid reform with SB 74, there was a bill passed and it was really focused on opioids, but it looked at Washington State's 7 best practices and how could we use technology to better share in emergency departments what prescription medication someone had with using the PDMP and other tools to be able to do that and to do these alerts. But then also a part of that got information back to providers about where that patient was going. And the Washington 7 best practices was based on the fact that Medicaid was like, dude, we can't keep paying you all so much money for seeing these patients over and over again in the emergency department. And so we're just going to cut you off after 3 visits. Well, that did not go over so well with the doctors. They got super angry. We have to see them regardless. And so Medicaid said, fine, you figure out a better system and you tell us. And they came back and said, let's try this 7 best practices. And the idea behind it is we'd have really clear guidelines over opioids, and we'd be able to see information regarding, what someone had been prescribed for and what other ER visits they would have. And what they found is that while they were trying to save, $3 million or so, that they saved, pull it up now, $9 million in the first year, just by having that information on where other people had gone. So some super basic, and please fact check me there, because it's been a while since I've 39 million. See, I was like, I gotta go low, so I don't remember exactly. 39 million, thank you. So it's been a while since I've talked about the 7 best practices with Washington State, but they saved way more money than they expected with just having some basic information about what's being shared. So that got passed in our legislature to say, okay, we're gonna do the same thing. And the Hospital Association spent a lot of time and money getting these ADT fees, these real-time fees from hospitals, so that Jason's not looking 6 months back, but can look a little bit more real time. And that, we can see more real-time information and that case management plans can be entered in. So now Christine sees a patient and she says, this is what needs to happen. She enters it in, and theoretically then the emergency department doc can see this person, this is the plan, or this is who you need to see. So you can see, and that's how we identify that this patient has 6 case managers, as we kind of said, okay, we called all the different insurance agencies and said, who's managing this patient? But he didn't know any of that. And there was a lot of hard work happening on the back end on this patient, that one, he wasn't aware of, and two, we as frontline clinicians were completely undoing every time they came in because we were unaware of the work that was happening on the back end and couldn't re-emphasize that point in that perspective. And then there's been built in, it's like a mini version of kind of what HA in like Maryland and other places, where it's just a much more robust system where that care management plan can be shared between providers. You can see what happens, resources that are available, like, you know, April's case list of what there is there in real time and accessible to be able to move forward, and kind of that hope and dream of how we can move forward such that all these incredibly hardworking people are able to see each other's work and build off of that, reuse what is there, and being able to build off that for a more effective and efficient system. And there's going to be a lot of it that Jason's team will be able to take care of completely on their own without anyone else needing to be involved. But there's a whole set of patients that Christine's going to end up seeing in a totally different way, and even her isn't going to be able to do them, and it might be law enforcement, or it might be others who's going to be then ultimately that kind of primary. So how do we make sure that we have a conversation with each other, multidisciplinary teams that are talking, that's enabled and empowered by technology, so that we're not relying on relationships, phone calls, and Excel spreadsheets, which seem to be the major powerhouse of our state's ability to get things done. And I don't want to discount those relationships, and I don't want Excel to go away because we could not function in state government without it. But I want to make sure that we think about what does that future look like and keep driving towards that future, rather than, I think particularly with complex patients, we're really amazing at admiring our past rather than thinking about where we want to go, and all of us moving towards that collective space together. So instead of going through additional questions, because we have about 10 minutes here, I wanted to open it up to questions from the audience, and got an amazing wealth of expertise here. I'm curious on your thoughts, your questions, your perspectives, thinking about complex patients and how we can reuse the information technology that we have, and how can we build new information technology so that we're not doing double entry for AKAIMS, or we can all see whose case management is happening, or OCS who's trying to manage a patient better, you know, put in that information so if that patient bounces into the emergency department, that doc can say, oh, this is a person who's in custody and we need to know about it, rather than undoing that space. So how can we collaborate together better? So open it up to you all. The line is stunning from that microphone right there right now, so. Yeah, come on up. It's like Price is Right.
Thank you guys for a really interesting conversation. I have a question about incentives. And, you know, to talk about the complexity of wraparound care and all these different silos in healthcare, I'm interested to know how the private practice community, the hospital community, the nonprofit community, how do you incentivize those different groups, whether it's a quality incentive, a financial incentive, ease of administrative overhead incentive, because it's hard to envision a 400 visit per year patient being seamlessly managed from primary care to case management, specialty care, without encouraging those groups to somehow work together. Thank you.
That's a great question, because this is a lot of time. Who wants to take that on first? Over.
This is on. Okay. I would, is it on? Okay.
Get close.
All right.
Not on.
Still on.
There it is.
There we go. Okay, sorry.
I will say that, I mean, the state does put out a lot of contract opportunities, grant opportunities, and we're talking, you know, prevention in particular, but that can be expanded, right? If we're smart about how we think about this, there are funds that support a staff person to help you, you know, do some work internally. There are opportunities for HIE development, you know, a little bit of money that's going to help offset your costs. I just, you know, you just have to be watching for those. There was probably other opportunities that I'm not aware of as well. We've got some funds from the state now that we're trying to be wise about how we connect within the state system as well, so that we can expand that out later.
Other thoughts on incentives? Or Jason, or Chubbin?
Okay.
Okay, so from the incentive perspective, you know, as a payer, that's one of those things that gets into a little bit of a sticky wicket for us. But as we move more towards, you know, value-based purchasing, paying for outcomes, some of those kind of things, I think that conversation, as that conversation progresses, is really where some of that incentive discussion happens. you know, at the end of the day, the Medicaid fee for service model that we have now is very much service, reimbursement for service, and it is blind to that incentive, you know, piece of the puzzle. And so as a person like this, as utilization comes down, the revenue that patient in theory generates at whatever, you know, practice A or hospital A or whatever, is impacted by that. And I think that's a really important part of the conversation. As we would move forward, you know, as we look at reform measures and things of that nature, to figure that out. I'll be the first to say I don't have it figured out, but it's a conversation I think the state of Alaska is committed to having, where we can influence that conversation. You know, we can't solve it for everybody, but we're gonna try.
Yeah, and I think that, you know, something else I wanted to highlight is you mentioned incentives and you mentioned it broadly, right? You didn't just mention like payment incentives, but you also spoke about like decrease administrative burden incentives and what that looks like. So I think that there's a bunch of different ways to begin, just like Jason said. I think we're really committed to thinking about from a payment model, how can we look at that differently? Two, how can we invest in things that decrease administrative burden, like the funding that came to the HIE from the state to say like, we believe this could be a potential service so that you can all see each other's case management, you can share records, and what does that look like to decrease that administrative burden? Quality metrics from another end is an incentive, like if this is a metric that you need to get, and a lot of the primary care and FQHCs have that. We don't have NACE and Merriman, a lot of FQHCs, but they have many quality metrics and having to have that data. And so they're incentivized for their quality metrics. So I think quality is another component of that. And then I also just think about the burnout for healthcare workforce, and you want to just do good for your patient, and to not do well for your patient is really demoralizing and really frustrating. And I think that if we can provide better tools for our providers to provide complex wraparound care for our patients, it's less demoralizing, it's better. Eric, I don't know if you have any other thoughts on that. You're working in that space a lot too.
I think like there's a really clear relationship with our medical respite program and the hospitals funding it to reduce costs, you know, partially to meet social mission, partially to support the community, and also that one-to-one relationship where if we have an individual that doesn't need an acute care bed in our hospital, instead staying with our medical respite program, there's a real cost savings to the hospital. So I think that there's like that clear incentive relationship for us to perform. We wouldn't continue to receive funding if we didn't. I think it's a really interesting conversation, like at the bigger scope. If we have social service entities that are maybe taking advantage of the 1115 waiver to provide case management services, how do we reward the ones that are providing quality outcomes in as far as reduced utilization of the system or whatever it may be, better care outcomes? I don't have a good answer to that, but I think the question's interesting.
I think this is just how I think every state's grappling with this. I mean, Vermont released a big care coordination program that is both kind of throughout the state looking at payment remodel and incentivization. Virginia actually launched a big thing that's very similar to the HUMS project across the entire state. And I think we're all kind of struggling with what this looks like and how do we do it and what makes sense for Alaska given our geography, our size, our different care sources. And that's why I'm grateful for you all to be in this room today to help us solve the problems together. Other questions or thoughts? Oh, is there a question up there? No, okay, just a comment. Awesome, well, I really want to make, do we have one more question? Go for it.
Mine is more of a statement. I've been to a lot of the national conferences where they're doing value-based care models. And what a lot of the driving forces is the cost of insurance. Our cost of insurance in Alaska for private insurance is going up, you know, exponentially every year. And I think where a lot of these demonstration projects have happened is they're like, if you're taking your caseload of your patients and private insurance is funding some of that and providing incentives because it's overall lowering their cost of care for their patients, a lot of times it isn't a state program that's going to reduce, you know, Medicaid is not usually the known cutting edge technology type, you know, system. And so I think private insurance in Alaska is going to be some of the driving force behind that.
Yeah, no, I appreciate that, not getting just specific on any one type of fix. I might push back. Medicaid's pretty innovative and doing some pretty amazing things within the state. But yeah, I mean, private insurance is about 15% of the state as a whole, but it is not alone. And honestly, that was one of the major challenges with this patient. He had private insurance, He was a native beneficiary and he also had Medicaid and Medicare actually. So, you know, each one of those had their own programs and systems to be able to help that patient, but none were knowing each other and talking about each other's role in that space. And also with dialysis, they're assigned a case manager once you're on dialysis by requirements. And so he also had that person in combination. I think that as you mentioned, we need to think about, while each of the payment systems can only change themselves, somewhat payer agnostic ways of addressing care. This came a lot with how do we define humps, like, okay, is this just gonna be Medicaid patients? Problem is people come in and off of Medicaid, they come on and off different spaces. And so we defined that group based on utilization of the emergency department at one specific place rather than payer. And we've got some payer initiatives, but what do we need to think about in sort of regions? I think one thing that I want to highlight is just with, again, the Matsu Health Foundation, and this is happening in other regions, like happening in Fairbanks and happening particularly, you know, the hospitals in Anchorage working around the complex work that's happening, having that conversation in your community about like what is needed in this community and who are the people we can bring together, and then how can we look at existing state services like the HIE or other things to build on that technology service and then figure out what that looks like. So if I've got patients who are waiting in my hospital for 6 weeks for IV infusion, for my endocarditis, for my IV drug use, I can't have, you know, Anchorage hospitals open to the rest. It's a money loser. And so then we set up beds to be able to say this is a complex patient who doesn't have another place to go, and how can we be able to use that? That's what we've seen in Anchorage versus what you're seeing in Matsu, slightly different than what you're going to see in Juneau, where you've got a public health nurse who might be able to get Tylenol on the EMS service, which I'm not sure has ever happened in Matsu that I'm aware of. So, you know, we've got different levels kind of based on kind of the complexity. So I really encourage as you go home to either think about your system and who's left out of the table to bring them into the conversation. Okay, if I have an insurer, if I'm private insurance, who else is managing this patient? Or if I'm in a region, who else is not at my table that I need to bring into this conversation on this complex patient? I'll oftentimes see incredibly hardworking groups of people in one silo working on the patient, and then you contact that provider and there's a whole set of providers working on that same patient and not talking to each other. So I think the big thing with complex care is just being aware of who else is doing what and being able to coordinate that. And I think we can use technology to really help that regardless of payer source. And you're right, healthy patients are cheaper patients, and healthy economies are built by healthy patients. And so there is a huge economic driver to this. And almost 20% of our GDP now is paid to healthcare as a whole entity. And things like a $10,000 deductible is not going to be inducive for someone to be able to access care. So how do we think about what does that look like in our systems in a community? But I would just really empower us as individuals as we're ending this, that you have a lot more power to change the system than you think you do. I get a lot of like, oh, if CMS just did this, if Medicaid just did this, if you just gave me, Dr. Zink, the $5 million you're sitting on, I'm like, I actually have somebody to give you, but that's cool, that this would all be solved. But most of the ideas come from communities understanding the levers that they have and working together. So utilize the levers that we have, utilize the HIE, utilize your community partners, utilize your resources, utilize the people on this table who have a lot of really great experience in complex care, and go back and figure out in your community, in your section, how can you manage and help empower the independence, the strength, the health, the well-being of some of these patients who are really calling for the system. So with that, I will turn it over, and a big round of applause for our panel. So thank you very much.
All right, let's give one more round of applause to everyone who participated this morning. We really hope that you will all stick with us through the rest of the day. I know these are quick transitions. We have really great speakers though coming up. We're going to take about 15 minutes. We have lunches available for you out the doors and to the right. We hope that you will collect those. We had intended for there to be tables, but we had such a great reception to this that we decided to fit more people in so that more people could participate. So they're boxed lunches. I know that you'll have to put them on your lap, but we hope that you will stay with us because we will have a really fabulous keynote coming up at 12. So with that, please collect your lunches. Please come back. I was going to do one of those read an intro takes forever, and she assured me that She was awesome at introducing herself. I would like to welcome Lisa Berry, CEO, Civitas Networks for Health to the stage. She's our keynote speaker today. The stage, all right. Great. All right, hi everyone, I guess almost for about good afternoon. As Brittany mentioned, I'm Lisa Berry, I'm the CEO of Civitas Networks for Health, and I'll talk more about what that is in a minute. What I wanted to say was I was thinking about, hey, is there too many slides? Is there too much detail? Is it gonna be, really hard to get through in the time we have today? And I thought I would give you sort of the bottom line up front first, just trying to contextualize this. And that is that Civitas is a national organization. It's a mixture of an association and a nonprofit, a mission-driven nonprofit that represents a bunch of organizations like Healthy Connect across the country. So we have almost every state, we have 160 total members, and they are really predominantly multi-stakeholder driven nonprofit organizations working on health data and health information exchange in some way. So there's a whole community in the rest of the country doing really similar work to what you're doing here, different contexts, different shapes, sizes, all kinds of things, but there are a bunch of organizations doing this infrastructure level work. That's the first piece. The next piece is there is an entire, multiple decades of work at the federal level, the national level on health IT, on health information exchange. Really, there's a long history, which I'll talk about a bit. But you should know that it's really at an inflection point right now. This is a really critical time where a ton of stuff is happening. There's a ton of laws being implemented, tons of regulations being written, lots of movement in the market, lots of private sector work happening. And so it's a really interesting time to be addressing this work. And then finally, Civitas and its members are working on this new concept, which we call health data utilities. And I'll talk a little bit about that as well. And we'll probably only get into the very beginning of that, but you might be able to see sort of how this work can continue to evolve in that direction and how that might be relevant to you. So that's my talk. I'm done. See you later. But I wanted to at least give you that sort of that's the point of this. If I bash you over the head with these slides, just remember those kind of main concepts I wanted to get across. So that's it. Let's see if this works. Always fun. So again, going to give you a brief intro. I'm going to talk about federal health IT and HIE policy. Going to talk about the progress we've made or haven't made towards interoperability at the national level, which you guys will relate to in your own lives. And then a little bit about the emergence of health data utilities and what's next and how to get involved. Okay, so who we are. Civitas is as I said, a national organization. It's both a member organization like a trade association and also in and of itself a mission-driven nonprofit organization. So our sort of tagline is regional innovation, national impact. And our vision is that communities across the country will be thriving and healthy, realizing the full potential of data-driven, multi-stakeholder, and cross-sector approaches to health information exchange and health improvement. We do not just represent HIEs, which I'll mention in a second. So this is a bad slide, believe it or not. I actually already had a designer try to help me with this, and it's too complicated still. So this is my interim approach to try and say, here's what we do and who we serve. On the outside, the red ring is sort of all of our member organizations. And we have data collaboratives and associations themselves. We have business and technology partners. We have all payer claims databases and health data repositories in different states. We have health information exchange organizations, community health improvement organizations, and quality improvement organizations like Quinn QIOs at the federal and national level. CoMagin is active in Alaska and also one of our members as well. So we've got a whole variety of different organizations who really meet those main criteria for us. The folks we represent are nonprofit, multi-stakeholder government, really important to keep saying that, and they work on these areas in some way. And they usually represent a specific jurisdiction or a couple jurisdictions, communities, regions, or states. And then on the inside, of course, is all the people who they serve. They're infrastructure organizations, so they have their own stakeholders. Many of you are stakeholders of Healthy Connect, so you can imagine
who all the stakeholders of our member organizations are. So it's complicated. And then we have programs, we have grant-funded programs and projects, and we also have member activities, educational, networking, all kinds of things that really help our members connect across different jurisdictions. Because it's important for you to know, of course, how is this work happening in other states and other jurisdictions? As you can see here with Healthy Connect, you already have the benefit of working with Chris and Chris from Shared Services, obviously also our members. So you get a little bit of that from your technology partners, but it is important to really be able to draw connections across different jurisdictions. That's what we do. So that's again, a really big slide. I apologize. I still have not figured out how to make it smaller or clearer, but we're trying. So that was that, and again, as mentioned, even though I said I would introduce myself, I didn't really do that, so let me start again. So I'm the CEO, and as you can tell, we created this organization to represent all these different stakeholders. It was the product of two other organizations that were in existence, the Strategic Health Information Exchange Collaborative and the Network for Regional Healthcare Improvement, and they came together in 2021. And I helped create the organization to where we are today with our team and all of our members. And before joining Chic and then Civitas, I worked at the CMS Innovation Center, the Centers for Medicare and Medicaid Services Innovation Center, working on primary care payment models, value-based care work as well. So I got a little bit of that to bring to the table. That's me. And I'm gonna try to give you an even worse slide that's even bigger, and apologize for it up front, but it's really hard to get the entirety of federal health IT and HIE policy on one slide, but I tried. And so again, apologies. And by the way, after this, I'll certainly ask the Healthy Connect team, they can share all these slides with any attendees. It's totally fine, as long as you give us credit for these amazing overstuffed slides. All right, this is an abridged timeline of federal health IT policy. Very abridged, but still has too much on it. So if you really sort of go back a little bit in time, there were various efforts to digitize healthcare. I'm sure that Dr. Quinn has some of that in his back pocket as well. Taking those beautiful paper records and basically copy pasting them into a PDF, let's say. So that was kind of some of the earlier efforts. There were a few really important reports, which those of you who are clinicians probably know about or heard of. The Institute of Medicine had a couple important reports at the turn of the century to err as human and crossing the quality chasm. It really said like, hey, there are all these medical errors and they're related to us not having the right information, and we need to deeply and quickly, drastically improve quality of care. And they really spurred some of the first efforts to move that stuff forward. So that was a critically important step. Of course, at the same time, in the 90s, EHR started to exist. There wasn't a lot of impetus for folks to adopt them, cost money, but they were building up, starting to come into existence and being used, but they weren't connected, of course, as we know. And so those reports happened, and there was really a push at the federal level to try to bring together data information. In 2004, President George W. Bush created the position of National Coordinator for Health IT. Eventually, it became essentially an office in the Department of Health and Human Services. This is important because it's not an agency. It doesn't have a lot of money. It doesn't have a lot of authority. Everything at the federal level comes from authorities that are granted to the agencies, usually through laws. And we still are in a place where the Office of the National Coordinator for Health IT is just an office in the Office of the Secretary with a pretty small budget relative to other federal agencies and not a ton of authority. We'll talk about some of the authority that they got recently though as well. So that was created. Then moving into 2007, as EHR adoption started to grow, we started thinking about what would a national health information network look like? How could we exchange health information across jurisdictional boundaries? And there were a variety of different attempts. There was the NHIN cooperative, which became eventually way down the road, eHealth Exchange. And just a few different efforts of like, should it be part of the government? Should it be a public-private partnership? Should it be totally private sector? We don't know what it should be. So a lot of, and you'll see that that theme continues today. And so there have been, long story short, there have been many, many efforts to figure out how to do a national health information network that have gone through so many different ups and downs over the years. And there, a lot of that was happening in the mid-2000s. And 2009, pretty big, you've been in healthcare for some time, especially all of you know about high tech and the attempt to bring in financial incentives for EHR adoption through things like meaningful use. I used to work in an EHR company, and the height of meaningful use, we were like, please adopt our EHR, we'll get you a lot of money from the federal government. And it kind of worked. I mean, certainly people did more or less in certain specific sectors of healthcare adopt EHRs. Famously, as we know, those EHRs didn't have necessarily built-in interoperability or exchange. There were some components of ability to export information, but not necessarily the built-in requirements or ability to exchange information easily using the same language, the same types of data structures. But we spent a lot of money on EHR adoption. We spent a little bit of money later in 2010 on the ONC State HIE Cooperative Agreement Program. So about $550 million was spent at that time to sort of try and get states to say, do something, designate somebody to be your HIE, and we'll put some money into it. And so that happened, but I would note, it's a tiny amount compared to the amount of money that was spent on EHR adoption. And so when I hear some concerns over time from my federal colleagues about, we don't know if we want to spend more money on HIEs, I say, well, you spent a lot of money on EHRs, and how did that go? Maybe put a little bit more into interoperability, you would get the outcomes you're looking for. So later on, here in the middle, 2015, there was also a really important law around quality programs in Medicare, MACRA, which you've probably heard of if you're a clinician or in the space. And that really focused on a little bit more on quality improvement, on the use of certified health IT in quality. Started really working on expanding some of those electronic clinical quality measures and programs like that, but it's still, you know, the type of requirements around use of certified health IT for quality are still very minimal, and they are really checkbox based versus really requiring, you know, submission, exchange, reporting that uses health IT to its full potential. We are not there yet. As anyone who is a clinician can probably attest, you're used to probably reporting into registries or dropping something into a CSV. It's not exactly the magical future where you press a button and it's there and there's no burden and it's great and everyone knows what's going on. Not exactly. Then in 2016, we had an important law passed, 21st Century Cures. And that law did a couple different things in the health IT space that are important, including giving some authority, some legal authority to HHS in different ways to both define and make information blocking, in air quotes, not allowed. And so there are lots and lots of details here, including the definition was pretty broad. They had the opportunity to find a bunch of exceptions and really, you know, figure out exactly what that would look like. And then they were like, and what are the disincentives? And who does them? Who's responsible for actually keeping an eye on these? How is it going to work? Say, so-and-so is information blocking. So all that stuff got worked out over a long period of time, many, many years of notice and comment rulemaking, which is how we do laws and regulations in the US, where we have to put it out and say, here's what we want to do, please comment. If we all disagree, then don't do it. And lots of delays for implementation. Of course, the implementation timeline overlapped with favorite COVID pandemic, and that also caused delays. We are now today kind of in the place where implementation is really happening, but there are lots of holes. There are always going to be lots of holes, because when you write a regulation now, I don't know, probably people were writing this regulation in the law back in 2014. That was a long time ago. The market moves faster than regulations can be written. Unfortunately, and also fortunately, it's a feature and a bug. And so the landscape for interoperability is so much different than when these rules were written. And the implementation and the problems we're seeing with that show it. So And basically, the final rules related to the Cures Act law were finalized and published in 2020. And ONC wrote a rule that they were required to write by the law, by Cures. And CMS also wrote a companion rule. I was a co-author on that rule. That was simply sort of using some of the momentum from 21st Century Cures to bring more interoperability requirements into CMS around patients being able to access their electronic health information in the form and format that they choose. And if you're familiar with HIPAA, you might say, HIPAA already says that patients should be able to access their information in the form and format they choose, but it just wasn't happening. And HIPAA is, of course, as we all know in our lives, used to block the exchange and the release of information versus making it available as it was intended. So we had to kind of double say, nope, really, we gotta make it available, use these standard APIs to make this information available so that patients can use any app they want to. There's lots of issues there, as probably you've heard already and know from your lives, but we'll get to that in a moment. So that's 2020, and then in 2021, that high-tech funding ended. That advanced, enhanced match from states, the federal government states to really allow for technology to be funded in a more flexible way, that's over. And now we're in the world of more limited, more restricted, more complicated Medicaid technology funding. And so we haven't had a replacement, we didn't have an extension, and states are still kind of looking around going, how do we fund this? What do we do? And what is the guidance for using this new, more complicated, more restricted Medicaid technology funding rules? It's not really there. So where we are today, 2022, we'll talk about that one as well. TEFCA, the Trusted Exchange Framework and Common Agreement, is the next attempt at the National Health Information Network, so to speak. Give you a little more on that too, but if you've heard anything about it, that's more or less what it is. Think of it in the continuum of this long work of thinking, how can we enable the exchange of health information across the entire country, which has been going on now for quite some time. This is the next iteration. And there's a bunch of additional federal rulemaking either already just happened or just released or on its way from the sort of rewriting and reimagining of the 42 CFR Part 2 rules around how behavioral health data is used, to additional interoperability rules from CMS and from ONC as well, to thinking about the final implementation and the enforcement of information blocking regulations. There's a lot happening that you can't necessarily ignore. A lot of this you can ignore, right? You can say, you know what, I don't really care if I get that extra 1% from CMS for the quality payment program. It's not worth it. We don't have the technology. We qualify for one of the exceptions, like we don't have the technology, we don't have the money for it. And so you've kind of been able to say hardship exception, like can't do it. This stuff is getting into the space where you can no longer ignore it. And whether Alaska is ready for it or not, whether any state is ready for it, whether any provider is ready for it or not, it's coming to you and it's not going to be able to be ignored. I think that's what I want to get across here is that there's a lot going on, many, many years, different laws, different regulations, and we are now finally at a place where it's speeding up and it's moving to a place where you can no longer ignore it, both from the demand side, from your patients, from your stakeholders, and also from the requirement side. So that's the timeline, very briefly. I want to give you a little bit, this is kind of just a slide where I just like to snipe at ONC and CMS. I used to work at CMS, of course, and I remember when we created this little timeline slide going through 2022, lots of steps. I can tell you half these things didn't happen, and that's pretty normal. So it's okay to kind of discount and say it might not happen fully, it might not be as hard as we think it's going to be, but there's always challenges, right? Legal challenges, practical challenges. The industry says, I'm sorry, we can't do that. For example, one of the CMS rules was around payer-to-payer exchange. The payer said, no, we don't want to do it. And I mean, I don't think they should have said that, but they did. They all said it together, and CMS kind of had to listen. So they took that out of the picture for the time and reworked it. Same thing with the ONC, right? There are riots from Kat in Incentive. She probably sent them a nasty ground and they stopped doing something. Multiple nasty grounds. And so, you know, there's always gonna be delays in implementation, so don't panic. But we are seeing sort of we are finally really moving that Overton window over to, it's time to make interoperability and exchange default. It's happening. It won't be dramatic and awful. TEFCA. So again, if you've heard something about, if you've ever heard this acronym, it's two things: the Trusted Exchange Framework, which is just simply a national framework for interoperability. It's based on existing frameworks. One of the biggest existing frameworks is Care Equality, very much in practice, used widely. A lot of Care Equality went into creating the Trusted Exchange Framework. It's not the same exactly, but there it is. And the common agreement is just the common rules of the road, again, based on existing frameworks that have been in place for a while. TEFCA was part of 21st Century Cures, and it was required, basically 21st Century required ONC to go forward with TEFCA and try and create this next version, the magical version that's going to make nationwide health information exchange a reality. The problem is, again, it was written in like 2014 or earlier, and it was written by people who shouldn't be writing a very, very detailed prescriptive regulation. Those details are really hard to do at the legislative level. It's really hard to get a member of Congress to understand a flexible way of defining a national health information network. It's really tough. And so the problem with TEFCA, which Alaska is going to have to consider and think about very carefully, is that TEFCA completely disintermediates states. Doesn't care about states, doesn't care about state laws, doesn't care about state rules around how you want to use your health data. It just says, hey, we're gonna exchange data, it's gonna be required, it's gonna happen based on the requests for either on behalf of patients or by patients. And so that's kind of an issue, and there's not really a solution yet. The good news, in air quotes, is that TEFCA was required under 21st Century Cures, and ONC was supposed to start implementing it a long time ago, and they just didn't. And they didn't do it for the entire Trump administration because the national coordinator, it's being recorded probably, didn't like it, and most people who would be in that role don't think it's a good idea. Now, we're in a position where the current version of ONC and the national coordinator say, this is our priority, it's our requirement, it's our responsibility, and they're gonna do it. And they're doing it in a way that is pretty equitable. It's been very multi-stakeholder driven to write all the rules, and it's taken a long time. And they have the process in place to basically transfer it to what they call the recognized coordinating entity, which is a public-private partnership, basically a collaborative. It's run by the Sequoia Project, who've been working on nationwide exchange for years, and nonprofit, multi-stakeholder governed. And so I think it will be great once it's actually in the hands of that nonprofit organization fully. It hasn't moved over quite yet, and they're just about to announce the critical first step in making TEFCA a reality. Is that we're going live, and we are selecting the QHINs, which are the qualified health information networks. In this little umbrella, you have the recognized coordinating entity, which is Sequoia, then the individual QHINs who are going to be managing exchange for different purposes. Everyone gets to choose which QHIN they want to join. They can only be part of one, and all the exchange will take place under that structure. So on February 13th, they're going to announce who the QHINs are, and then we'll see how implementation goes. There are plenty of possible paths here, but TEFCA, should it be successful, will definitely affect you because you will be part of it if you are part of a broader organization who decides to join a QHIN. It's not currently required. It's not currently part of any CMS quality programs or Medicaid or state programs or payer programs, but it could be very, very soon. So this is something to keep your eye on and think about how you want to be part of it or not, or if you even have a choice based on your health system or your EHR or a program you're in or some other requirement that gets connected to it, because CMS and others are working on connecting TEFCA to various programs under CMS for providers to follow. So the problem again with this is that it's not really, doesn't really care about states and what states' preferences are. I'm gonna stop editorializing. I love TEFCA. I do love National Health Information Exchange, but I'm not sure that the structure is gonna work out as planned. I think it will adopt and change as people give feedback and as they see what actually happens on the ground. And that's good, right? I think fundamentally, clearly, I think that health information change is a good thing. That should happen more, we should use it more. So as I said, more federal policy making on the horizon. The 42 CFR Part 2 changes, which are trying to align the way behavioral health data is treated across HIPAA and Part 2 are coming. They're already out. And the comments are due on January 31st. That's really important. I assume if you're in the space, you're familiar with that because it is a critical change, long requested, long needed. The CMS has another rule, a second interoperability rule that touches on prior authorization. That's out now on the street as well as a proposed rule. It's due at the end of March. And they have a bunch of things like stakeholder calls that are coming up. So take a look at that if you're interested. ONC is finally looking at information blocking disincentives for providers. The first rule that they finalized in 2020 only talks about disincentives and rules for health information exchanges, health information networks, other players like that. Doesn't touch on providers. Currently, there is no disincentive in place for providers of all stripes who information block, again in air quotes. And now they are saying they're about to release, they're planning on releasing this year, a proposed rule that talks about how providers will be implicated. That authority was given in 21st Century Cures to the HHS secretary, but they did not immediately write any rules around it or do anything about it. And now they have decided finally to do that. So that's happening. It's a big one. That is the one to really keep your eye on, I would say, and respond if it affects you. And then finally, all the information blocking stuff that was finalized, except for the civil money penalties that that accompany the finding of you were an information blocker. It was proposed to be around $1 million per incident. It has not been finalized yet. It's coming any day. And so once a dollar amount is put out there on what it could cost you to be branded an information blocker, I think we'll also see some actual movement in the market. Good and bad, right? If you know the number and you're a huge hospital system and you don't care, maybe you won't change your, maybe it won't be enough to change your behavior. Maybe it's not enough money because you can fight it in courts, right? You can say, I qualify for exception A and exception B and exception C. And if I finally am found guilty of information blocking, it's only $1 million and I'm a multi-million-dollar hospital system, maybe you don't care. You should care, obviously, but maybe you don't care. I think money penalties in American business have gone both ways in terms of either continuing terrible behavior or stopping it. So we'll see how this goes in the business of healthcare when you connect it to money penalties like this. So lots happening really soon. And by the way, I have some links in here for information about these different rules. So if these are released, then you can certainly check those out as well. Okay, so I just gave you a bunch of slides and a bunch of stuff about federal health IT policy, which I am clearly obsessed with. So I'm in the right business, but it's a lot. I think, again, the piece I want to really hand over to you here is there's been a lot of stuff that's done a little bit, poking around, pushing a little further, but now we really are starting to get to that inflection point. And so if you're in this space, if you're a clinician, if you're staff, if you're supporting in some way, you're not going to be able to ignore this for much longer if you have it. Not to imply you've been ignoring it, but that it's getting very, very real for every type of healthcare provider and everyone in the industry, even tangentially. I think we're going to see that be much more serious in the future. So more to come. So all that stuff happened. Have we, at the national level, made significant progress towards interoperability? I mean, obviously I heard the panels today, the speakers today. And a lot of the challenges that people are facing here in Alaska are similar to challenges that are being faced in almost every other healthcare market, every other state, region, jurisdiction. I think obviously resources are lower. You know, the ability, the baseline infrastructure is not as much there. But unfortunately, even where there is infrastructure, where there's been significant investment, you still see people doing the dreaded paper bridges. I have been like frustrated about paper bridges in healthcare and care coordination for now a decade. And I've only been in healthcare for a decade, and it started the very first second I stepped into an EHR company and said, oh my gosh, why are we doing these paper bridges? And they're still there. And so I think there has been significant progress towards interoperability generally in the country. And also there are still tons and tons and tons of silos and tons of paper bridges that still exist today in 2023. So I have a little bit of information for you here. We have, this isn't perfect, it's now already a little bit outdated, 2023 now. This was done in 2019. What is the industry progress towards deep interoperability? You know, what does that mean? That's when you're, let's see what the definition here is. This is the percentage of customers reporting optimal response at each stage. So electronic access, record location, clinical view, impact on care. The 2017 is the yellow, the 2020 is the blue. So you're seeing, when you measure it, you can see that we are doing more in a fully electronic environment. But then if you probably know from your own life and practice, you know, there are still so many gaps. There are still so many paper bridges. However, we are starting to do more work at the data element level. Dr. Quinn said earlier, showed sort of the difference between a PDF and the data elements. That's a really critical piece for deep interoperability, again, in air quotes. I'm doing this because there's no video feed, by the way, so I keep saying in air quotes. Not because I like that. And so one of the critical pieces for that is this thing called US Core Data for Interoperability, which is really defining those standardized data elements for API-driven exchange. And that continues to grow. We're on version 4 now. Version 4 was just released. That's getting bigger and bigger, and they're thinking about going beyond the basic domain of clinical healthcare. They're moving into what they call USCDID+, which is across social care, public health, other settings. So we are starting to say, okay, standardized data elements, you have to be able to move them around. Here's the baseline requirement. That's really important as it gets adopted more broadly. That is relevant. And then, as I keep saying, the enablement and the requirements of using HL7 FHIR APIs, which you've probably heard of before in this group, basically standardized interfaces between disparate health IT systems. They're becoming more and more used. They're becoming more and more available. More and more EHRs are starting to enable these API interfaces. It's still limited though. And then also there is more and more there have been more and more attempts to engage patients to use and access their own healthcare data. Through portals, certainly. I built a portal back in 2013. Wasn't very used because portals, of course, require you to go and log into them separately and see a tiny bit of your own data versus accessing all the data. But more and more patients care about seeing their own data to some extent. Patients who really need help often don't have time to grab their own data, use it. Patients don't like to be the ones who have to carry their own data from place to place, either physical or electronic. They want to be where care is happening. They don't have to do that themselves, but they are getting more and more awareness of that they should be able to see and use their own data. That's great. And then more and more incentives for data sharing are happening. They're still quite limited. However, really my main point, this is actually my main point. This is my only main point of this entire presentation. Competition between healthcare entities, misaligned incentives, and poorly enforced requirements, and unwillingness or, critically, inability to change workflows. That's the biggest barrier, continued barrier to healthcare interoperability that we will continue to be. That was true a decade ago, it's true today. Those things are still there. And so those are cultural changes. They're not law changes, they're not regulation changes, they're not even necessarily money changes. They're really cultures, communities saying, okay, we've got to figure this out. This isn't the right way to go forward. We have to try and address these things. You can't do this just by regulation alone. You can't do this just by money alone. It has to be that critically multi-stakeholder, equitable, cross-sector work to say, we have to make this better together and stop using those paper bridges. So that's what I think is the biggest barrier still today. And my opinion has not changed for a decade. We're not gonna be able to have enough time to really get, this is a big issue. We've been talking about clinical healthcare data, talking about clinical data interoperability. When you start talking about bringing in social care data, well, that's a whole nother presentation. That's another couple of hours that we don't have today, because there are even deeper, more complex issues around social care data that we certainly shouldn't be applying the same viewpoint, the same perspective as we do for clinical data and clinical data interoperability. Consent management is even more important. Standardization is not there. Even more of a lack of technical infrastructure, if that's possible. Deep concerns, justified concerns about information collection and sharing, the broad capacity of the sector, and then, as I mentioned, the unnecessary medicalization of SDOH. Public health, I didn't have a slide here about public health. It's both easier and also harder somehow, if that's possible. The authorities are easier, but the actual practice is harder, if that's possible. So just copy paste some of this over to a public health data slide as well. So we're just talking about clinical data interoperability. Get to this section, we say, okay, we have a lot more work to do. Am I doing? Not well. Okay. Great. I have 15 more slides. This is again, sort of a roundup here. When you think about the national and nationwide interoperability frameworks and networks versus the community and regional and statewide HIE organizations like Healthy Connect. The progress at the national level over the last 2 decades really points to nationwide centralization, consolidation, and a very EHR-centric view of interoperability and data exchange. But the problem that I have with that is that data governance, health data governance, probably should be happening at the community, regional, and statewide level, because the preferences and the needs and the specificity of your community here and many communities here in Alaska are very different than that in Maryland, where I live, and Craig lives. And so, you just bringing everything up to that nationwide level really misses the critical agreement and multi-stakeholder work and collaboration that has to happen here. And so I can't go fully into that view that we have one nationwide health information network and that's it. In fact, I don't think it's possible, it will ever happen. And that's some of it's very much by design, the way that the United States is structured, our federalism, our legal structures, our states, huge country, tons of people. Side story. I used to live in Germany a long time ago, and I was a teacher. I taught English to teenagers, which is really not a good job. And I was only like 22 and they were like 19. So it was really a mess. And they would always say to me, like very arrogantly, like, oh, Americans don't know anything about Europe. Don't know anything about all of our, don't understand like our countries or structure. And I was like, do you know what the capital of Iowa is? Because we have a massive country, huge geography, totally different people and different priorities and preferences. And that's really relevant when you think about federated data, when you think about bringing together something that covers the entire country. It's totally different. So, teaching English to 19-year-olds is not good. not good at all. Don't recommend it. So, I'm actually almost done. I'm going to try, not going to go through all the slides. So going back to this for a second is, again, so everything at the federal level is moving towards nationwide health information network. And I'm saying no. And I'm saying no because obviously I represent an organization that represents a bunch of state level health information exchanges and quality improvement organizations who really focus on the preferences and needs of people in those states and regions. But also, I just don't see it, I can't see it with our legal structure and the outlines of our country and the people in them and all the different cultures. And so a lot of that is what gets us to this next concept, this idea of health data utilities. We know that we need better data and information in our regions and states. And we know that some of that data and information can be shared much more easily across state boundaries to federal entities. And if we have those strong entities at the state level, we can enable better exchange at the nationwide level. But it has to respect the governance rules and the priorities and preferences of those individual regions and states, those entities, those utilities, let's call them. Not like the power company, but still in some ways like it, in that we have to provide equitable and services that reach all parts of your community. People have to have the roughly same services around things like health information exchange to help the entire state or the entire region. So really quickly, I'm only gonna have a little bit of time here. We have this emerging definition that we call health data utilities. And we, Civitas, didn't invent this, it was invented in air quotes by many of our members who are doing this work in their specific state entities. And you know, bringing together this idea, we were picking it up and trying to bring it up to the national level so that everyone can learn about it, figure out how they might fit into that concept. So our emerging definition is that HDUs are statewide, roughly statewide, some big states that are complicated, California, Texas, New York, Florida, for example. But most states will have roughly one entity or one approach that combines, enhances, and exchanges electronic health data across different care and services settings for treatment, care coordination, quality improvement, and public and community health purposes. They really focus on combining and enhancing data across different domains and jurisdictions, clinical, public health, social care data, anything that's needed for that community. And they really enable specific and defined use cases with extra protections that go beyond the baseline federal protections for health data, or state in some cases, to ensure patient privacy protection. And they really need to, and this is the critical part for us, build on existing infrastructure. It's not about saying, Alaska needs a health data utility. Let's get a RFP and Palantir is going to bid, and we're going to award to them, we're going to build a health data utility. That will never work for lots of reasons. And one of them is that relationship infrastructure is as critical as technical infrastructure. People who know each other and work with each other and have that trust and that relationship, that's as important as the technical underpinnings. And I can tell you, I have seen this across now almost 50 states, and I have talked to all these people, and it's the same issue. Everybody wants to say, let's RFP and award the health data utility contract to Deloitte. And sorry, Deloitte, if you're listening. And that's not going to work. I'm equal opportunity against Palantir, Deloitte, McKinsey, you name it. Because it's not going to work to bring in an outside consulting firm to do all of the work. It has to come from the bottom up with the community that's already there. You can try it certainly if you have unlimited money and time, but you don't have unlimited money and time. So that's the broad idea. Again, there's so much more to say, and I do not have time to say it right now. But here are some basic principles that have to be there. You need state policy levers of some kind, including incentives and or mandates, depending on your state and how you work and how the people in your state work. You need broad stakeholder participation. You need people from all these different sectors to be engaged. You need the state, you need the providers, you need patients, you need payers, you need everybody to be involved at the table, similar to the structure that you have right now with Healthy Connect, with the board being very multi-stakeholder. One edit here. The utility is not, in this case, Healthy Connect. The utility is the service to the entire state. It could be coordinated or organized, or much of it could sit with one organization, but it's not a business entity. It's not Healthy Connect in this case. It is something for the entire state. You need mature use cases in place for Medicaid and public health. They have to be there. We see it time and time again. You've got to have those use cases present and active. They drive a lot of it forward. They are not exclusively the only use cases. And you need multi-stakeholder, transparent, corporate and data network governance. And you need really high standards for data privacy that go beyond baseline federal laws. Those are the baseline principles for you to keep in mind and think about how you would create as a community here. Again, I am like way out of time, but I'm gonna skip ahead and please know that these slides will be made available to you. And you can see what else is in here. You can certainly ask follow-up questions. All right, gonna skip, lots of great stuff, so many great examples, no time for them, sorry. So in terms of what's next, I've got a few questions to leave you with. And these are really questions for you. I can't answer them for you, certainly, I shouldn't even try, but it's really about how can your local communities lead in integrating healthcare and social care and public health data systems? What is a vision that you could create together or an idea like health data utility in Alaska? And then this is a big one, which we'll talk about in a moment. We have a panel right after this. How do current health IT, data collection and data use workflows help or hinder care delivery and outcomes? And do they mirror those previous paper-based processes? Are they paper bridges? Or have they been actually adopted and adapted for modern interoperable technology? And then finally, are you prepared for the implementation of these more advanced federal interoperability regulations? And are your health IT and HIE partners prepared? What is their answer for all these issues around information blocking, for example? And then this is apparently a trend, so I didn't realize, and I figured it was gonna be a trend. So, is anybody prepared for the emergence of new AI tools? So I wrote this entire presentation, and then I went to ChatGPT, and I asked it to write the presentation for me, and I had like a better answer, of course. ChatGPT is a little bit of a gimmick, right? It's not great. It's not necessarily true, but it's meant to seem like it's true. But it had pretty good answers here for what are some problems with health data governance, like lack of standardization, inadequate resources, privacy and security concerns, data silos and complex regulations. That's pretty good, right? I didn't ask it, I just asked it one question. I didn't even train it or try and make it better. So that's pretty good. There is a big opportunity to find signals in massive amounts of unstructured data with AI. It's not really here today as much as we'll try and tell you it is. We can't just feed it a bunch of OCR and PDF documents and say like, figure it out. But maybe in the future we can. I was thinking of the analogy to, in some other low resource settings, they were like, well, should we lay the telephone cable or should we just wait until we have cell phones? I think, yes, to some extent, but you can't skip that critical infrastructure building and hope that AI will solve it in the future. That's not gonna happen in the time frame we have in front of us, but it will potentially help. So you do have to build the infrastructure, but you might be able to skip one or two steps later as technology continues to expand and move forward, like the emergence of AI. So just something to know about and be aware that it's coming in the future, as well as regulations, by the way. There will be more and more regulations about how we use AI in healthcare that are not there yet. So again, it's not going to be the easy button. It's not going to be, you can skip all the steps and just move on to AI directly. That's not going to happen, unfortunately, but it is a trend that we should be aware of and think about as we move forward. But and I do think they could have written my presentation, so probably should have done that moving faster. All right, so next steps. Those of you who are in Healthy Connect's community broadly, Healthy Connect is a member of Civitas. We have all kinds of news and announcements in the industry. You can keep in touch with us on our website. We have a great personalized, uses machine learning, which is sort of maybe one interesting application to figure out when to send you the right information about news and events, industry news or events, things like that. We have public webinars, things that you all can join that are called Collaborators in Action if you want to keep up with the industry. It's just something you can do there to get involved. We have a conference every year. It is in National Harbor, Maryland in August, which is going to be great, very warm. And it's going to be a great conference though. We're going to talk about public-private partnerships really extensively. And then of course, please get involved locally with your peers here at Healthy Connect Alaska. And yeah, that's it. That's what I got. I'm gonna stop the share, and I'm going to ask my panelists to please join me on stage for our next panel. Oh, no. Wait, it's not locked. Maybe not. As long as that's fine, as long as all right, we're about to shift into the panel, which is the second innovation roundtable, perspectives from Alaskan healthcare leaders. Talking about where we're headed with interoperability, collaboration, and innovation. And so I am super happy to also moderate this panel, leading off of my sort of overview from the national perspective. And I have actually asked, as before, I've asked the panelists to please take a few moments to introduce themselves. Start with Katie. Then let's see.
You all have to talk really like.
Yeah, please bring the mic like right up.
Can you hear me?
Yes, you want me to take it out of the, yeah.
That's okay, I can leave. Probably good. Hi, everybody. It's nice to see you. It's good to be here. I'm Katie Baldwin Johnson. I'm the Chief Operating Officer of the Alaska Mental Health Trust Authority. The Alaska Mental Health Trust Authority is a state corporation that administers the Mental Health Trust, which is a perpetual trust to ensure that Alaska has a comprehensive mental health program plan to support Alaskans that experience mental illness, chronic addiction, traumatic brain injury, intellectual and developmental disabilities, Alzheimer's disease and related dementia, and other disabilities. We function very much like a private foundation, unique in that we are a state corporation, and we utilize our resources to support system change. And that's through a variety of mechanisms. That's through funding, innovative programs, and launch of new programs, grant making, partnerships and supports to different state partners so that they can mutually support some of the initiatives that we're working on. As well as technical assistance and other trust initiated projects. I don't know how far you want me to go into other things. Introductions first.
Yeah, let's just do introductions first. Lisa.
Okay, there we go. Hi, good afternoon, everyone. Nice to see you. My name is Lisa Aquino, and I'm the CEO of Anchorage Neighborhood Health Center. Anchorage Neighborhood Health Center is the largest community health center here in Anchorage. We've been around since 1974. As a community health center, we are a one-stop shop primary care center. So our mission is to assure full health care for people here in Anchorage, and to remove as many barriers to that care as possible. So with that in mind, we provide integrated care. So we have an integrated behavioral health model with our primary care. And then within our building, we have a number of services that are all there on site for our patients to receive while they're there. So we have lab and x-ray on site, as well as mammogram. We have a pharmacy who works with all of our patients, as well as a clinical pharmacist who's working in our primary care setting. And then we have a dental clinic on site as well. And in a move to really reduce the barriers, there's a few specific things I just want to make sure everybody understood about the barriers. So some of the barriers that we see to healthcare are, for instance, language. Many of our patients, English is not their first language of choice. And so we are providing care in multiple languages. We are working with and coordinating care with our patients in terms of transportation. So these are just some examples, and it's very importantly in terms of pay. So as a community health center, we receive a grant from HRSA, and that is to help to cover some of these services that are not billable. And and in addition, as a federally qualified health center, we can bill Medicaid and Medicare at a slightly higher rate that then pays for some of those wraparound services for patients. And so that's really important to remember. So between Medicare and Medicaid, that makes up almost 70% of our patient population, about 65%. And then we also provide care to many or uninsured patients or underinsured, and we have a sliding fee scale to help to make care more accessible to them. And we see about 11,500 patients. That last year, that was our number. So just to give you a sense of what we're doing, really interested in talking about data and technology and working together. So thanks.
Good afternoon, everybody. My name is Ross Dodge. I am an internal medicine physician and owner of Eat Neurology and Sleep Medicine here in town. And I actually don't have any idea why I'm here.
You have some pretty good
I've been
thoughts on the topic.
I've been roped in, and I joke about that, of course, because I have a deep interest in both the quality of care and the sustainability of care here in Alaska, which is a hyper-fragmented market. Our practice is small. We have 4 physicians, 6 nurse practitioners, and I want to say 40 people that we employ right now. And my perspective is a little bit unique within our practice, and it's kind of how I got to know Dr. Quinn over here as well, is that I spent 10 years in the Air Force, and at time of separation, I kept my relationship with the VA, and so spent quite a bit of time over at J-Bear Hospital, VA side of the link. And then I do work in the community at outlying and more rural hospitals, working as a hospitalist, and have a couple of sleep clinics that are set throughout the state. So I've got some of the perspective from the large federal entities, which are a very uniform control structure. And then I have a viewpoint from the private practice marketplace, which, like we spoke about earlier, the degree of incentives in that aspect of the healthcare system are obviously very different. And I think just my opening comment would be is that I had listened to a fascinating podcast a couple of months ago that was trying to differentiate problems into whether problems are complex or as to whether problems are complicated. And I think the sharing of information between multiple entities that have very different motivations is a very, very complex problem. But when you look at it from within the hospital model, clinic model, the patient model, I don't think that it's very complicated. And so if we take a big step back and ask the question of, can we even do this? Is it possible to integrate all these different systems? I think it's a resounding yes, because it's not a complicated, unsolvable problem. There's just an extraordinary amount of parts that go into this, which makes it a very complex thing. And so I'll stop talking here in a second and the microphone, but I think that's my interest and perspective on that, is that there's a lot of different working pieces. Everybody has their own stake in the system. But at the end of the day, we're all going to be a patient at some point. And if we can't make this work by our level, and we can't make it work for the patient, which means at some point when I need the system, my mom needs the system, then it's just not possible to have efficient or effective healthcare. So I look forward to the discussion.
What a great topic to come together on. I don't know about the rest of you in the room, but I really appreciate what you just shared, because helping bring us all together and say, what could a vision look like? What do solutions look like? What's coming? How far have we come? I think is a really good use of time. So thank you all for being here. My name is Sherry Hinshaw. I'm an independent contractor born and raised in Alaska and mom of 3. My kids are Pepper, Fletcher, and Sloan. They are my life. I will die here in Alaska, and I'm pretty committed to this state. And I'm committed to their future and their wellness and the wellness of their friends and the next generation here. And that's my why for doing this work. And I know that all of us are here because we have a pretty strong connection to helping create healthy communities and healthy Alaskans. And so being able to come together on how do we address these barriers that are really impacting the information flow so that each patient can get the best care possible is a really worthy cause. I am serving as the interim CEO of the Alaska Behavioral Health Association, which is a trade association representing about 75 behavioral health providers across the state, community behavioral health nonprofits who provide a range of services. You met Josh this morning. Is he still here with Alaska Behavioral Health? Providers who are doing innovative and expansive things every single day. Victoria with Canna, I see Jeannie with Vicky Child and Health, Child and Family. And they are really stepping up to meet the need every single day in the community. Within those 75 members, they serve in aggregate about 20,000 Medicaid beneficiaries. So Medicaid is the primary payer mix for most of ALAPA members. One thing that you'll hear through the course of my comments today is that behavioral health is really financed, structured, and regulated separately from the broader healthcare system. And that plays out in a number of ways, including how fractures happen and a lack of coordination. And a lot of this is rooted in stigma and how behavioral health, our history of behavioral health in the United States is really still developing. And there has been a lot of recent changes due to COVID where behavioral health and wellness is being thought of differently, is more, there's really cultural norms around the acceptance that behavioral health is health. And we have a real opportunity of where we are in the development of behavioral health and the focus on whole person care to really treat individuals as whole people and not separating the head from the rest of the body. So it's a really exciting time. And so how do we start to address the consequences and impacts of those separate systems that right now create a bit of an othering of behavioral health when really we need to come together. So really excited about the brain power in this room. And I am confident that we're going to be able to figure this out. We're a lot farther ahead today than we were a year ago. And I know a year from now, we're going to have done a lot more. So thank you.
Yeah, wonderful. Well, as you can see, this is a really interesting and qualified panel with a great set of perspectives from across the landscape here. I don't know everything that happened over the last couple of years. I know a little bit of it from a national perspective. I think the critical piece to focus on is truly how multi-stakeholder collaboration continue to move you forward. And that was some of the tenor of what I was trying to put across here, is that it has to be this collaborative effort. So we have a couple of broad questions. We really want to spark a discussion here. We've got about 45 minutes. We might have a little bit of time for questions, so you can start to think of them if you have them. But we'll just go through them a little bit. And again, really encourage people to jump in or ask questions or add to things. I think the first question I want to talk about is, I mentioned quite a bit that provider burden, administrative burden are massive issues nationwide, right? They are ever present, and the exchange of health data, things around care coordination that require the exchange of health data, those are just huge issues everywhere. They probably show up a little bit differently here in Alaska. I would love to hear from each of you, from your work, examples of folks you represent or work with directly. What does that look like here? How does administrative burden show up in exchange of data or interoperability efforts in your work? Maybe I'll just turn it right back to you, Sherry.
Well, and I mentioned when we were prepping for this that I could probably talk about admin burden all day long. I think I see Farina and Lauren. Yes, they're like, we've heard you. But they're part of the solution, and I really appreciate the partnership that they bring in wanting to get our arms around this. What is admin burden? And really it's duplicative. How we're defining it at the Behavioral Health Association is it's duplicative, irrelevant, and non-value added tasks that take clinicians' time away from delivering patient care. And so thinking about, as I mentioned, those separate systems, behavioral health, you talked about 42 CFR, there's regulatory changes, both regulatory structures that do create barriers to care, barriers to communication, as well as a disparity between medical systems and health systems on the documentation standards and requirements. So for instance, if you go see a primary care provider and say, I've been depressed, I need some help, they might write you a prescription. You might get some integrated care like at Neighborhood Health Center, and really be able to access that with a certain amount of ease, which would be an ideal situation. In behavioral health outpatient settings, documentation standards would require a comprehensive intake, assessment, intake, multi-step process that really does delay care due to additional requirements on behavioral health. There's also issues like, if I used to be the CEO of Volunteers of America Alaska, which is a youth behavioral health organization that provides services in schools and shelters, outpatient and residential. Each of those settings have their own compliance and regulatory environments. Housing, that's one set of requirements, healthcare is one set, licensing and facilities is one set. So the administrative burden of having multiple layers of compliance and audit, you're going from one audit to the other. And multiple data systems. So you have one client who's experiencing homelessness, you're entering that information in the homeless management information system, you're entering the minimum data set in AKAIMS, and then you're interacting with your electronic health record. And you have to hire staff to do that duplicate entry. Often that information doesn't come back in a meaningful way that helps you improve your outcomes as an organization or improve health outcomes as a community. So really looking at how do you establish meaningful outcomes across care settings that can be used to both inform care at an agency level, but inform care at the community level and address gaps that are there. But you have to have that ROI for the agency or incentives on collecting and providing that data to really make it a part of the practice and sustainable.
I mean, have we looked at all convincing anyone to eliminate any of those duplicative entry notes ever?
I have hope. I'm a hopeful person.
That's good.
Yes. I do think that federal changes around parity and a focus on it has, and behavioral health integration, whole person care, really modernizing, and the whole idea of starting to align payment requirements around outcomes. It really, I think, will, I'm hoping, start to address some of that. And I appreciate our state partners in the room that really do and are prioritizing how do we do this, because this is a workforce issue. Administrative burden is a workforce and access issue. So when one provider is spending half of their time on documentation, that's half time that could be seeing more patients. And honestly, I have talked to parents whose children died by suicide on the waiting list, and that is something that keeps me up at night. So when I'm talking about admin burden, that's the why of dealing with that, is so that clinical providers can see more of the need we have in our community.
That just makes me think too, Sherry, just hearing you say that. So, I mean, I know at Neighborhood Health, we, and I know that my partners in primary care are doing this as well. We have done so much to build this team-based approach, which is incredible, and it's so great, and it's built around the patient. That's the idea. Because of administrative burden, we're finding that we're hiring team members to just do more administrative ticks on the checklist, and it's not about supporting the patient. It doesn't feel like it is, and that's a hard position to hire, someone whose job is just box ticking. So just to reiterate that, like, it's about certainly the providers, but every level of people working in healthcare, because people get into this work, into all of the work that we're talking about, social services as well. I come from that field as well. They get into the work to really serve people, to work to create a better community, and that's hard when all your time is spent box ticking.
Yeah, I love this question, because I think it gets to the heart of the issue, which is, and I'll give a quick vignette, which is there will be times when I'm on call, particularly at a military base, and And I will have a laptop open to access my community records to try and access health information exchange.
There you know where this is going, it's not good.
And then I have one computer open that is the Department of Defense computer to access patient records. I have a third computer open, which I use to access the VA records. And then I have a fourth computer open so I can get to echoes, EKGs, and remote labs from the prior system. And it's insane. I mean, what should be a 45-minute admission can take me upwards of 2 hours, and half of that time is spent simply logging in. And then if you forget your login password, I have to call Larry, the IT guy, and his head explodes when he watches me open my cell phone with my list of 45 different access passwords, which is not encrypted and sitting on my, I mean, it's nuts. But I think the point of the discussion here is that the system is at risk of getting in its own way. And that's exactly, I think, the comment that was just made about you build data to make data extraction better, but you have to have a person to mine that data to make data extraction better. And I don't know where that ends necessarily. The second part of this, of my response, is that I have lots of people that work with and for me whose sole purpose it is to go through and do this stuff behind the scenes. And I question sometimes what component of providing healthcare that individual is doing, because there's nothing that is clinically relevant or medical in terms of medical management that's being done. Is to do back-end processes so that we can either get paid or get scheduled or coordinate with somebody else in the community to make the care outcomes better. So, I mean, as these things get put together, I think it is imperative that the systems are practical and workable. Because we're never going to be able to recruit a 1 or 2 physician practice, of which there are a striking number of in Alaska. That's not something that exists in the lower 48. But if we can't get those provider groups engaged in an information sharing model, then we lose, because they're not going away. That's what patients want. They want these private relationships with independent doctors. And if the system doesn't capture them in a way which makes sense for the provider office to do, it's really, really hard to get to the broader goal of having kind of throughput of information along all aspects of care.
That's so true, and I'm gonna pass it to Katie, because I already said something. I'm just gonna say one other quick thing. And that's this, that just listening, I was thinking, so before I became the CEO at Anchorage Neighborhood Health Center, I was the CEO at Catholic Social Services for 7 years. And what I'll say about that work, it was incredible and so motivating and almost completely unregulated in lots of ways, especially in terms of working with the homeless population when we were a major provider in that field. Now, and then I moved to Anchorage Neighborhood Health Center, where I'm in healthcare, which is the complete opposite and very regulated in all these different ways. And as we have an opportunity now, as we're talking about health information exchange, and because we're so far behind here, to actually come to maybe the middle in terms of how we share things. And I think that's an opportunity that we should really think about. And I'll pass it to Katie.
Thanks. I think with our role here as a mental health trust, we're not quite, boots on the ground and don't have the practical day-to-day experience with dealing with the administrative burdens or whatnot. In my prior roles, I do have that experience and understand what that's like. But in terms of an advocacy organization that focuses on policy, we are very much so interested in seeing expanded and enhanced access to care so that individuals that need care can get it in a timely manner where they need it and the appropriate type of intervention. And some of these additional administrative burdens that have been described are they're issues that everyday organizations are dealing with that impedes access to care. Not intentionally, perhaps, but it's just the system that we have today, and it's evolved over years and years and years of regulations and federal requirements, states implementing, practices to develop data systems and whatnot. So I think just in terms of a policy level and an advocacy and thinking about systems and supporting providers and organizations that are serving beneficiaries of the mental health trust, it's really important that, we think collaboratively about how we can begin addressing some of these issues that have been identified.
So if you step back a little bit to the federal level or national models for care, whether you're talking about SAMHSA's model for behavioral health, or you're talking about, CMS's various structures around quality reporting, or HRSA's or any other agency who sort of in some way, shape, or form touches your work, and from the federal perspective, they now all of their models and frameworks include health IT or some type of data exchange as best practice or a requirement or a something, right? And so that's great, except for, as we've already established, in various settings, including in Alaska, the resources to do that work or access that health IT or even HIE services or data exchange services are pretty limited. In some cases, not there. When in my earlier talk, when I was talking about meaningful use, as we know, those original resources only went to a very narrow subset of providers, and in many cases completely skipped behavioral health or completely skipped long-term and post-acute care. Various other segments are just completely out of the picture, and there wasn't ever money for that. So what do you do? How do you meet these national requirements? How do you meet these national models for best practices when there isn't the infrastructure available, or it's much harder to get to? How do you start to bridge that gap? What's working, and then how do you keep it sustainable? So probably just ask you, Sherry, to jump in on that. We were talking about before.
Okay, great, thank you. SAMHSA wrote in 2011, it's called I always forget the full name. We always just call it Good and Modern, but descriptions of a good and modern addictions and mental health system. And I'm going to read you the section on IT, because when I read this, I thought, yes, that. I want that to be our vision. Okay, to achieve optimum individualized care, all holistic outcomes measures and indicators are collected, stored, and shared with the individual and providers who are associated with their care. Interoperable integrated health records are available, as well as community-wide indicators of mental health and substance use disorder, with appropriate security mechanisms, informed consent, which drive the system, and account protection of individual rights to ensure appropriate linkages to services. That. And
You want that?
I want that. Because what I hear from providers across the state, which to be realistic, APA represents, as a trade association, members that have 5 employees up to the largest health systems. And so it's a wide variety of technological capability as an agency, or staffing or resources towards this. We did survey members, and less than a quarter of behavioral health providers who responded make regular investments in technology. The bulk using sporadic grant funding when it's available and when they get it to invest in that. So there's organizations that are on paper that want to move to an electronic health record but don't have the capacity to do so. So there has to be investments both at the agency level and bringing up their capabilities, as well as the system level. If I could take one step back, just looking at behavioral health, like the state of behavioral health in Alaska, it's a very fragile system. As a result of chronic underfinancing, and with many programs funded through kind of patchwork, like and duct tape, and a little bit of spit and a lot of trust support. And there isn't necessarily a vision for where are we trying to take the system of care? What's the infrastructure and backbone support for organizations doing those services to get them there? So what happens is when you have a system that's fragile, it's and under-resourced in some settings, it weighs heavily towards other settings. So what's happening in Alaska is more acute services, more emergency room, high-cost services. And so who pays and who saves? And those are not in balance. So we have to rebalance the care continuum and rebalance the investment. We have resources in the state. We have the ability, we have a relatively small population. If we can come together around the vision of rebalancing that continuum and making those investments in other ways, but it means that we have to have a period of time where we're sort of double investing in where we are today in a kind of crisis response system to investing in the future and have that shared vision. So I think it takes a lot of leadership and continuing to chip away at it and work on it and not give up. And I don't know if some of you, if your brain hurt a little bit after Lisa, I was thinking, okay, that's a lot. I'm gonna need to. But we do have expertise, and with these national folks coming in and helping us, we can do it.
That was a really hard question, so I'm glad you sat to my left. I don't
Yeah,
need
I agree. Yeah, we agree, Sherry. Well, I think, and what Sherry described for behavioral health, I think is so important and so true, and it's true for healthcare in general. It's true, definitely true for health centers. You know, as community health centers, we are, as in receiving federal funds, we have a lot of reporting requirements, and they take a lot of capacity, right? So when you think about, when you look at our staffing, you know, we need to build that capacity in, and we have an incredible people who, at Anchorage Neighborhood Health Center who are doing that, and those people could also be doing more that's more focused on our patient care model, right? But there's this large amount of work that needs to get done. But I would say, even if that was possible, we're pretty efficient at what we do. And that's just the HRSA requirements and our universal data elements are just one thing. And we have multiple models. And I'm sure that this is something that we all have in common on some level, but we have all the CMS requirements. And then we're also a patient-centered medical home, which has, that model has requirements that we need to meet and follow. And they're really great. Like, they're great. They're important and critical to what we want to do. And we want to live up to all of those. And even just saying them out loud, if the ability to streamline some of that, in particular, if we could do that at a city or a statewide level with our partners, would be so helpful for our patients. I mean, I think in this conversation and in this issue about like trying to, you know, these reporting mechanisms and let's just always remember why this matters, right? It matters because of the patients. It matters because of all of us walking through the door and wanting to deserving to receive the highest quality of healthcare all the time and of care all the time. And also to be able to access my records when I want them and to be able to understand what's happening with my health. So if we could just keep that at the center, that's another thing that kind of makes, when I think about all these reporting requirements, it helps me to get through the day.
I just want to add, just jump in there really quickly and say something as well. I think that you made a comment, Dr. Dodge, about the landscape here and it's somewhat fragmented, lots of independent providers and entities. And, you know, I made a comment earlier about, you know, the competitive nature of health data and keeping health data for yourself. I think you still need to be concerned about that, but you need to interpret that to whatever makes the most sense for this market broadly or these markets broadly. And some of that's still going to be there, right? Even, you know, physicians in private practice becomes competitive, probably not at the same level or the same motivations as huge multinational nationwide corporations who are running, you know, consolidated health systems in other states. Some of them here too, but really you see huge amounts of consolidation and massive corporations running healthcare and owning everything. So that is important to keep in mind. It is still here to some extent, but it's probably not anything like it is in, let's say, Boston, where you literally have to carry a disc across the street from big health system to big health system because they will not do it in any period of time that's appropriate for your healthcare.
Yeah, that's interesting, and I think that that's true. I think we definitely still have it in my experience, I'm sure. And probably not to what you're talking about, it's still, we're still a small enough community in terms of people knowing each other and being able to pick up the phone, that it's some, that
Trust being a
some
little
of
bit
it,
more obvious.
but you know what? It's real. The issue about competition and what you're talking about, it's real. And it's challenging, you know, when we think about these changes that we need to make, you know, there's gonna be a lot of pressure on the system as it was, which relied a lot on relationships and just, you know, sharing and goodwill. And the reality is we're a part of like nation and like multinational data sets now, and we don't have, and those relationships, they're still true, but we're gonna have to buy into these bigger systems, and it's hard. You know, we at Anchorage Neighborhood Health Center just moved electronic health records, and we moved to Epic, and wow, it was hard to move. But we're in Epic, in the Providence Epic, and one thing that's amazing about this is now we're in this pool of data. So it's like an interoperability pool of data, and it's incredible in terms of what access there is. And it's also, and I wish everyone could have it. Also, it doesn't have everything in it yet. Yeah.
It probably never will.
Okay. Well, I would just, I think just kind of shift a little bit back to some of what Sherry shared earlier. You know, we're really talking about how do we work with the existing parts of our system that are siloed, and how can we identify those solutions to best de-silo the system so that we're providing more effective care and we have better outcomes for the people that we serve. Overlay that with, okay, here's where we are now. Just in thinking about initiatives that are coming down the road, and they're in the process now. The trust has been partnering with the Department of Health and Department of Family and Community Services and local state government and tribal health organizations and communities across the state to think about how to design more effective response to people with psychiatric and behavioral health crisis. Across the country, it's law enforcement, emergency rooms, and jails. And so that's part of that collaboration that takes everybody coming together, you know, within a community to actually think about and design what you want that to look like, so that ultimately people are getting care at the right level, and identifying what programs and services that we don't have that we need to build. And when you think about the communication that needs to happen with that, it's not just healthcare. Behavioral health is healthcare, but we have to pull in our partners, our law enforcement partners, our emergency responders, our community hospitals, our behavioral health providers, and all of the services, the safety net services in communities where people need to be re-engaged so that they can be safe and stable in the community. So that's a whole nother like piece of this. It's complicated, but thinking forward, you know, what is the vision, and who are the folks and the voices and the perceptions that need to be involved in that, so that when it is designed, that we're really working towards something that, you know, hopefully we'll be thinking about, you know, I think the end goal, which is better care for people, better access, and better outcomes for individuals.
Scott, you want to talk about the sort of how we fund and access IT and how we maintain the sustainable investments from your perspective?
That sounds like another hard question.
It is.
Yeah, and so that actually was going to be, I didn't look at the rules for being a panelist participant, so I'm not sure if I'm allowed to ask questions.
You totally are.
But
Any panel that I'm moderating, you're allowed to ask questions.
yeah, and so I think that what I was curious about is brought up well with the question about how do you finance the model of this information exchange, which just has to be just huge in scope. Because that money has to come from somewhere. The guy that puts these pieces together, software or hardware, he's got to get paid. And so what I was curious about is we have a unique marketplace that is small and geographically diverse, but we all live in the same couple little bubbles, right? You live in Anchorage, you live in the valley, or you don't. And everywhere else to me is just like other places in the state of Alaska, which is super unique, but I think that there is a ton of opportunity within that because there is so much local or individual involvement. I had a dinner months ago that the governor was at. I had been invited, and it was shocking to me at the end of the night to think that at my level as a young, newer provider in my early 40s, have interface with state government to the level of the governor, which is, I think, extraordinarily uncommon if you're in California or Maryland or places like that. So to get back to the question, what I'm curious about is in other models that you have had insight into, who are the drivers that make the financial piece of that come forward? And is that healthcare systems? And if so, do we need to more aggressively engage with ECA, HCA, or Providence Medical Group? Is it the individual provider groups? And if so, how do we get them? I mean, that's like herding cats to get 40 different clinical practices to speak with a unified voice. Or is it these larger associations that you guys represent that take care of, I mean, really the most unfortunate portions of our population, to come up with a model that works for that population? Because if you guys make it work, then, the insured truck driver or the teacher who has, a dual health insurance plan, it's going to work for them as well.
Well, so I studied health policy and got to read a lot about it, and I got to actually experience how policy was made inside of CMS. And then I got to look at all these different models across the country and see different organizations sort of finding ways towards, on a long path towards this idea of health data utility. And the thing that is consistent throughout is that there are some states that have great coordination from the state level, where there is an entity or a collaboration that came together to say, we got to do this thing together. In Maryland, there's been pretty great engagement from the Department of Health, and they even have a separate sort of mini agency that is tasked with kind of looking over all of the HIE-like organizations in the state. They are, and that exists in a similar structure in New York, more coordinated. It's beginning to exist in California, not through one organization, but through a data exchange framework. And there are other states where there's that coordination. But for the most part, across the country, in terms of just sheer numbers, it's about the payers. Because in the US, as we know, like who pays for healthcare is really complicated. There's usually a couple of layers of abstraction from the actual delivering of healthcare services. And so not always the case, not in every situation, but going back to who is paying for healthcare is one of the fastest drivers towards alignment. And it's tricky here because you have a pretty broad variety of federal and centralized payers. And then, like you said, a different landscape of providers that is less consolidated, significantly less consolidated than other states. And when you get down to competition, certainly there's competition between payers, but there's a ton more competition between providers and big health systems, generally in the country. That's where you're seeing most of the, I don't want to share, no. And you're also seeing, not to call you out, this is not meant to be negative in any way, shape, or form, but when you look at like a big health system, they say, look, you can have our Epic install, and now you're part of this big data lake for interoperability. You said it yourself. You don't know what you don't know. There is a lot happening outside, and they will tell you, you're here in our interoperability land. It's great. You can exchange data, but you and they don't know what they don't know outside of those walls. And that's why we find that it's really important to have this multi-stakeholder health data utility-like resource that engages many different types of stakeholders in the service of exchanging data to improve patient outcomes. That does not stick within one of those little areas, or bigger, but also still distinct areas. So I think that's the sort of short answer is mostly it's the payers, and mostly it's aligning with how we pay for healthcare and what we can do to make that go faster and ideally be more efficient, cheaper, better quality, meeting all the goals. And so that's like, I don't know how well that's gonna work here, but that's the best answer I have looking across the entire landscape. That help?
Yeah, it does. I mean, I guess my blunt response to that would be you just have to follow the money. I think there's a lot of things work across the board. And if you go to where the money trail is for providing these type of contracts that encourage better interoperability, you can probably find the funding for those 1 and 2, doc shops all the way up to large health trusts.
Yes, and I would also say, it's the job of the community who's bringing this together to say our organizing principle is improving healthcare for people in our state, and to keep that as the most important thing that you're pointing towards, and not let the money take you down a path that you don't want to go. And that's the community's job, is to make the money do what we need it to do for you.
That's what I was thinking about that as well, is just to make sure that right, that the patient voice is there at the center. And because, as we were discussing this panel earlier, like an issue as we move towards that, towards this nirvana where we're all together, please keep in mind that there are some systems that are much more built out around data sharing and using data than others. And in creating the new one, please keep those in mind, because a lot of work has gone in, like, because community health centers are required to do this. As community health centers, we've built in a lot of systems. Please don't build something totally on the side and not take that into consideration. I only mention that because that's happened before with things. So, and we're just one. Like, Tribal has built incredible systems. Like, let's keep that in mind. The VA has required systems that they have from the federal government. So just to keep that in mind.
Well, you're bringing up actually basically my next question, which is wonderful. So let's move to that, which is really saying there are different data silos in every healthcare landscape, every state, every region. And what's really important is for the state and to some extent for the federal government to know what are those silos that are pervasive that you're facing, and what should they do about it, right? I understand that everyone has a different relationship with their state government and how they work together. But one of the great things the state can do is they can put forth policies that, start to shape that landscape. And they really almost can never do it without the active participation and engagement of the other stakeholders, of the people in the market, the private sector, and the community. But they certainly can play an important role. Going to the payment side, in other states, in some cases, they have really strict requirements for Medicaid managed care around data sharing and exchange and funding that. That's one of the slightly more innovative ways of funding this work long-term. If you have a big Medicaid managed care population, the contracting requirement is you've got to do this. You've got to pay into this and be a stakeholder. You've got to be part of it. So that's just one of the ways you can do it. So I think going back to the question about what are the data silos that your policymakers should know about and care about if they don't already know, or what you'd like to really impress on them. And what do you think they should do about it? And I probably would go to Katie and say, what would you like policymakers to know about the data and interoperability and exchange issues that your stakeholders are facing?
Well, that's a
Big question.
Well, I think, just reflecting on the trust and how we work, we really rely on our partners, our advisory boards, and the relationships with our associations that are there to support their networks of providers that are supported by those organizations. And so, it's important for those groups to really make sure that they're organized and thinking about this and paying attention to this, and then developing their priorities around this and figuring out a platform for communicating that in an organized and coordinated way. I think that's one of the ways that the trust has really worked. We're state government, but we're also kind of not state government. Don't let anybody hear me say that. But it's just that we kind of can sort of, be neutral in a lot of ways and support, different perspectives and helping to support folks moving forward with solutions. And I think the other thing I would say is that, you know, when you look at the disparities, the lack of parity in the system, in the healthcare system, you think about the organizations in the healthcare system that are serving individuals with intellectual and developmental disabilities, those associations, they're barely making it. They don't have the bandwidth to focus on interoperability. You know, they're just trying to get the direct service professional to show up and make sure somebody can get out of bed. You know, the behavioral health providers, there's really a range of the same kind of thing. So it comes down to bandwidth, comes down to, I think, those kind of resources. I think some of these organizations are going to need capital funding and operating funding to help with this work. There's technical assistance that organizations need to be able to access. And then I think also some of this like infusion of some additional resources. And, you know, I think philanthropy plays a role in that and needs to. We need to look at all available resources for this. But, you know, how do we help organizations know what they need to know that they don't know? And where is that resource to dispatch to people? Where I'm an executive director and I'm just trying to keep the doors open and I'm trying to keep my workforce and I'm really focused on this. So I think, you know, it's there's several angles to that, but I think we really have to recognize the additional support that organizations are going to need to figure this out and really to rely on one another. The learning between organizations and successes that, you know, you went through, you know, changing your health information records. And you know, it's complicated, but, you know, Alaska is a relationship-based state, and we work really well. That's one of our strengths, is that, you know, we step forward and we help each other.
That's great. Well, we are really close to out of time, so we want to do a quick, just everyone try and keep your remarks relatively short, where we talk about what do you want policymakers to know about these data silos and these issues that you and your stakeholders are facing.
Well, I think I've had plenty of time and I've shared mine, but what's on my mind right now that I'm going to leave you with is that a large senior care clinic in town closed, and there's a bunch of Medicare patients that are going to be searching for care. And wouldn't it be great if we could do some sort of looking at their risk and making sure that the highest risk people who need their meds refilled could get sooner into somebody else? If we had this, I think we could maybe do that. So that's the dream.
I'm up. Okay, so first, thank you. This has been a very interesting conversation. If I was sitting in front of the person writing the policy for this, it would be, you know, I like government intervention to be at a bare minimum, but that minimum has to be representative of individual safety. So somebody has to look out for somebody who nobody else is looking out for. And to that end, the way that this probably comes to fruition is that you have to cajole different parties who may not have their own incentives to get to a unified program. So the payers are going to have a certain set of incentives, the hospital groups will have a certain bunch of incentives, individual providers will have their own incentives, and of course the patient. And so the state's responsibility is to come in and look at all those different incentives and understand who has to give some up to reach the greater common good. That is a broad statement with very little detail intentionally, because I think that's where the devil lies. But, you know, as a collective group who, you know, has obviously a lot of impressive people in this room, I think that's where we have to push, is to make sure that the state's responsibility is to understand who needs to be directed, so that the person that ends up in your clinic with no primary care provider and no source of care or can't get out of bed is cared for in a way that I can see those records in the ER. You get access to them regardless of you're with Epic or Cerner or whatnot. So challenges ahead, but it's an exciting time for a first summit to see where this goes over a couple of years.
When I think about data silos and providers I've talked to, it's really about a lack of communication between care settings, between emergency rooms and outpatient settings. You heard from Josh at AQ Behavioral Health, some amazing things that they're doing there by connecting to the HIE. So I think it's elevating these success stories, elevating things where we're making changes and it's improving care. So I appreciate the work that's being done here on that. I think that as a patient, you would hope that no matter where you're receiving care, your information follows you. And so that's really the dream. And as Lisa, thanks for grounding us in that. I think that's really important. And then the final thought would be, the Behavioral Health Association has talked a lot about our goals to really push aligning service delivery, provider payment, quality, and training towards whole person care. And that is centering it around the individual. Rather, you're not going to eliminate data silos until you eliminate the fractured care system. And I really appreciate bringing us all together from many different backgrounds. And I know this is a first conversation of many, but it's us staying committed to it. I think that'll be really important.
That's great. Thank you all so much. I actually, again, lied. Have time for questions. We did have a great question come in, however, from the chat about how we make sure rural needs and rural communities are included in planning the implementation. And I would just like say, I have a secret as well, which is that actually I have family in Alaska and they live in Tennecky, which is not in any of the places you mentioned, Dr. Gott. It's really far away. It takes 30 minutes by seaplane, 4 hours by ferry, and there's about 50 people there. And I'm sure that they are not being included as a stakeholder in a lot of this work. And I'm sure that there's a way, and that's obviously a question and a challenge for this group to really consider as you think about, what comes next in building these plans and services. It costs a lot for them to go anywhere. And so I'm sure that they're not, directly included, and they should be in the future as well. All right, well, that's all the time we have. Please join me in thanking this incredible panel. Can you hear me? Okay, so we are actually going to take a quick 10-minute break because we need to move some things around.
And Brittany and the Department of Health, and this has been a really fun day. And obviously this is gonna be the best panel, but thank you all for coming here and for doing this. This has been a lot of fun. I really appreciate it. Okay, so I'm Frank Bem. I am the CPO of Crisp Shared Services. We offer essentially the information technology infrastructure to Healthy Connect. And the whole purpose is that they have really great people, really great connections on the ground. And we have reusable technology that can be scaled and shared across a bunch of different states. So the same thing that we're building out in Alaska, we built out in Maryland and Virginia, and DC, and West Virginia, and Connecticut. And we think it's exactly the right thing. So I can be up at night thinking about security issues and people hacking in and all the things that technology companies worry about. While the team here can worry about, are my providers happy? Are we doing the right thing for our community? What's the next big data source we need to flow through? What features should I make the technology provider order on this? So it's been a really, really great collaboration. I'm really happy to be up here. I've also only been in Alaska in November and January. So I propose the next one of these should be in July. But thank you. So we're gonna end. I think this is going to be hopefully a very optimistic panel because you've heard a lot about the need for evidence-based decisions and some of the reasons we want interoperability and even some of the policies that would help make providing the healthcare services more effective, in some really difficult care settings. Well, the folks here, both on stage and virtually, have actual experience taking data and doing good things with it. And so that's what they're going to tell us about. And I'll make sure I have questions for you all also, so be thinking about that as they're talking. But let's just go down the panel. Everyone's going to take a few minutes to talk about who they are and what they're doing. I'm actually going to start with Sarah, who's doing a really great job joining us virtually. Sarah.
Hi, can you hear me okay?
Loud and clear.
Yay, excellent. Well, thank you for accommodating me virtually this week. That's been unexpected, but I really appreciate it. So I'm Sarah Oslo, and I'm the program manager for the Alaska Immunization Program. And as you know, vaccines have been a pretty hot topic, especially the last 2 years. And it's been a wild ride. So we have been looking for ways to get our data into the hands of Alaskans. And one way we're doing that is through Docket, which is an app And it connects directly to our immunization information system called Backtrack. And Alaskans can register through this app and view their own vaccine record. So that's, in a nutshell, a way we're using our data to get it into Alaskans' hands.
That is perfect, thank you. And then we'll start on this side of the table.
I'm Chad Jensen. I'm the office manager.
Turn the microphone on.
I'm Chad Jensen. I'm the office manager with Latouche Pediatrics. Been there about 17 years, and I really like working at Latouche, especially because they're very forward-thinking of the data type of stuff. And so when I started there, we implemented EHR, and ever since then, they've really pushed the envelope to make sure that they're trying to lead the way. We've been involved in implementing Backtrack, way back in 2007 and 8. The HIE, we were first in the nation to meet meaningful use requirements. We're part of the EDDI program with collective medicine, and we just continue to do different types of things like that. And so I really, really enjoyed that part of working with Latouche. But we're also see primary care as our main focus. As much as I love doing data all the time, but we do see primary care patients and behavioral health. And we have locations in 2 in Anchorage and 1 in Eagle River. So it's really neat to be able to help patients by implementing this new technology in positive ways.
Good afternoon. My name is Farina Brown, and I'm the active director for the Division of Behavioral Health. And it is a pleasure to be here today. Interestingly enough, I think all of you are clearly aware of that there's a lot of conversation and interest about behavioral health data. I will not be addressing all of those issues this morning this afternoon, because that is a wide and complicated conversation. And as one of my colleagues likes to say, we don't want, if you're going to make clear, calm, concise, articulate points, I'm not going to argue with you. What I'm going to say is that the solution moving forward with regard to data is multi-stakeholder engagement. We are always happy to be at the table and engage with where are the gaps and what are the needs. We are, as I heard this morning, there was a lot of conversation about AK Ames, and while many of you have very strong feelings about AK Ames, it is our resource for responding to and fulfilling our state and federal data obligation. It also serves as a free electronic health record for many of our behavioral health providers and has for about a decade. So we do recognize that it's a bit antiquated, and we are moving towards a data modernization project that's across the Department of Health that will really help ensure that we have meaningful data that informs our community at both the behavioral health provider level and thinking about the individual as a whole person. We recognize that data-informed decisions are the only way that we are able to move forward and make meaningful change at the mild to moderate level before individuals are engaged in our crisis continuum that's only in its fledgling state, that reduces individuals sitting in a psychiatric emergency department that is not the most appropriate level of care, and that creates that upstream impact that we're really looking for. When we think about data at a systems level, at state level, it's not just a one and done solution, because there are so many multiple components that come into play. The doctor that was on the panel before really talked, and he said something that was important, but maybe might have been missed, is the level of complexity that's involved when we think about how do we address data, how do we bring all of the stakeholders together. But it's not complicated once we can get through the complexity. So I'm really pleased and fortunate to be a part of this panel, and I'm happy to always be at the table to listen. And how do we bring everyone's voice together in a meaningful way that creates a solution, but also understanding and being incredibly realistic about what does that cost and what does that take? Because there's no magic money tree that allows us to say, here's the data solution we want. We always have to be mindful around how do we bring together a solution that's meaningful for Alaska, that is timely, but also ensures that we are paying attention to what that cost as far as being able to ensure our patients, providers, and stakeholders have access to data. And we can do this in a timeline that creates relationship, but I really hate that I missed Josh's presentation, but allows for that instant access. And so these are all points that are not just an easy one and done solution, but I appreciate the opportunity to talk through it.
Can y'all hear me okay? Yes. Okay, here I am. I'm Dr. Victoria Kildall. I'm the Behavioral Health Director for Kodiak Area Native Association, or CANA. And I think I was a little mystified to be invited to this panel, but one thing we're working on over at CANA is looking at clinical outcomes and how we can make real-time changes as we're gathering data in our care for patients with our clinicians. So that's really a project. We've recognized it at different levels that a couple things. One, the term quality is often conflated with compliance, right? That if you're accredited or if you check all the boxes, like some people were talking about earlier, that means you are providing a quality service, which is a misnomer, right? So we recognized that and decided to kind of, we've got the compliance pieces, but also to figure out what's our quality through the client's lifetime of services with us, right? And then also to realize that productivity does not equal quality either, right? That just this access thing, which is huge, and I really respect all of the comments that have been made about we need access, we know we need access, we need quicker access, we need better access. But also to realize that once they get in the door, the actual services provided, there's not always that guarantee of clinical quality, right? So in our organization, we are working on a routine outcomes monitoring program that allows us to, in real time, figure out if a patient is deteriorating and employ clinical skills and clinical supervision to get the client back on track. So I'm happy to talk more about that in this panel.
Hi, my name is Ruby Freed. I'm a assistant professor of health science at University of Anchorage in the Institute for Circumpolar Health Studies. But today I'm here in the capacity as a Alliance member, Alaska Alliance member, and a contractor. The Alliance was established just in 2019 and is a system shifting network of multiple and diverse partners across Alaska who recognize the impacts of alcohol misuse and related harms on individuals and communities, and who are working to reduce them in Alaska. And we are personally and professionally committed to working together to address this complex issue in our state. This is a project that is housed in Recover Alaska, but is really making strides to create a statewide network of people who are thinking and working in a networked way in order to kind of democratize data use, data collection, but also just any actions or services related to alcohol misuse and related harms. As the Alliance really deals, it's focused on alcohol misuse, but it really focuses on prevention and as a holistic concept. So everything from culture as a protective factor down to clinical services. So I think I'm here kind of both zooming out a little bit from the conversation and also zooming really deeply into communities. Let's see here. The project is it is a project of Recover Alaska, and it's funded by the Division of Behavioral Health Comprehensive Program, Prevention and Early Intervention Services Grant. This is not usually my part of the presentation. And UAA in our capacity has supported the Alliance in many ways in terms of data. We've done some regional data scans identifying data needs and data equity concerns across the state of Alaska. We have done some data collection to support underage alcohol and youth prevention action. And most recently, in the last year or so, we have been hosting a data and learning work group with the aim of increasing data equity and justice in data collection and decision making. So us, like everyone here, really believes in data-driven decision making, but that is really hard in many ways in Alaska on the community level and regional level because of a lot of barriers that have been discussed here and some barriers that haven't yet. And data equity might be a semi-new term for folks here, but it's my belief that health equity, which you might be more familiar, is not really going to be possible without data equity, especially if we're relying on this decision-making or data-driven decision-making and data-driven care. So data equity refers to the consideration through an equity lens of the ways in which data is collected, analyzed, interpreted, and distributed. So it's a complex issue because you're working with data in multiple different stages. And I think one of the main ones that isn't always wrapped back around is getting it back out to the communities and allowing them to make local decisions about resource allocation to fit the direct needs of those communities themselves. So I'll be talking a little bit about that.
That sounds great. Thank you. I think, Ruby, you said it really well. We want to zoom way out and probably way back in. I find when we talk about data is like this big amorphous thing. Everyone wants data. Like, oh, if I just have behavioral health data, or if I just have real-time data, it's not really meaningful. And so one way to get down to the meaning is maybe to ask, what is a problem you're trying to solve? And then what thing will solve that problem? And so if you could all, I know, maybe we'll start with Victoria, to get an example, but I know Chad and others have probably done this too. Can you describe kind of a problem you had, and then the piece of data that helps solve that problem?
Sure. To provide a little context for everyone, the routine outcome monitoring program that we've initiated at CANA is a little over a year old, so we're actually still in the early stages of the program itself. A good outcome program takes about 5 to 7 years to fully get up and running, fully be totally, running in that we're gathering meaningful data. So I just want to preface it that way. But the problem that we identified was that we hadn't figured out a good way to gather, hey, did this work for you or not? I mean, really, it's that simple. Are our interventions working? And when you think about interventions, and my personal opinion is that unfortunately we have veered so far into this is the evidence-based treatment, so therefore I should use it, that we've actually missed the person-centered care piece. So that was the other part of the problem or the question that we had is this really what our people need? So right, if you have an evidence-based treatment and you deploy it and you implement it, that hits what, 65, 75% of people is a positive intervention. But what about the other people, right? So what we are trying to do is we're trying to address the question of what's patient-centered care by saying we are going to build it from the bottom up instead of top down. So by bottom up, we provide the intervention and then we gain immediate feedback from the patient. Did that work or not? If it did not, we adjust. And we adjust through the clinical supervision process. So that's really ultimately, if I could categorize it, it is this patient-centered? Is this what our people need? And that's the question we're trying to answer.
That's great. Anybody else want to describe a problem and how data solved?
So
Sure.
Let's go to Sarah first.
Sorry, I can't tell. I'm jumping in over people. I think COVID vaccine, we really wanted to have a context for where we were falling short in getting vaccines out to Alaskans. And in Backtrack, all vaccines administered in Alaska are required to be reported within 14 days of administration. But data quality has been a continual challenge with some of our immunization data. And with COVID vaccine especially, we slowly rolled out a requirement to include race and ethnicity data with our COVID, with all vaccinations reported to Backtrack. And that's really helped us understand where we're falling short in serving communities in Alaska. So that was a data challenge we had that COVID vaccine really highlighted, and then a way that we got around that. And the another problem we had was people not having access to their own immunization record. If people weren't sure when they were due for their next vaccine or what they were due for, or if they received everything they were recommended for. The guidelines were really confusing and complicated. And we started off with a paper request form about 2 years ago. And I'm really happy that now we have an electronic app people can use for that. Thanks.
So with us being a pediatric office, vaccines are always really important to us. It's all just piggyback. As one of my examples is with COVID and all of our vaccines, it's so important for us to have that stuff that's in Backtrack immediately inside our EHRs. And so we have like a bi-directional interface with Backtrack, and all of our immunizations come right into our EHR. The providers never have to look at, so our immunization records are always up to date. So that's a cool thing. I've heard that mentioned a couple of times, but I think that's how Backtrack has really helped us. But probably one of the biggest things and that impacts all of our patients, because all of our patients have vaccines. But one of the things I really, really like about the project that we did is this emergency department information exchange. And what the system was, and I think Dr. Zink talked about it earlier, was where all the emergency departments are connected together. You can see what happened at another emergency department and see what's going on with those patients that might be bouncing from one emergency department to the next. So what we did is we partnered with them and we're able to upload our patient empanelments. We just do this on a weekly basis and it's all automated. And what happens is if one of our patients go to the ED and they don't say, hey, I'm a patient at Latouche, we automatically get notified of that the next day. And this almost doubled the amount of ED notifications that we were unaware of, right? So we always, typically they'll say, I'm a patient at Latouche. The provider will work them up and do whatever needs to be done, and send us a follow-up discharge summary saying, hey, this is what happened to one of your patients. And we follow them up saying, hey, sorry, Johnny went to ED, what's going on, and follow up that care. Well, with the EDI program, we were able to now, instead of double that number, and now we're able to follow up all of our patients that's visit any Alaska hospital, and it even includes hospitals and some in Seattle as well too. So we're able to then follow up on those patients the next day, then identify those high ED utilizers, see why they're going to ED, prevent them, try and help them prevent them from future ones. And even some of them, like, hey, had a cough for a week and decided to go to the emergency room. Well, so we'd be able to also have conversations with them because we're open 7 days a week, 8 to 8, so we have lots of availability and lots of time. And we'd say, hey, why don't we try to help you in our office where it's the right care at the right place at the right time versus, already going to a high, to the ED where they're, very, very busy already and they have critical care patients that they're needing to see. So I think that that's been a really, really neat project, how we've taken data and then reutilized it to help not only patient care, but healthcare costs within Alaska, trying to reduce those by having patients receive care in the right spot.
For the Division of Behavioral Health, data really helped and was the driving factor in our 1115 waiver. We were able to use a variety of different data sources to inform and as the very first step in how do we create change in our system. Data informed the gaps in our system that were manifested and approved by CMS in the wide array of services that are now made available through the 1115. One of the very basic premise of what we hope and we are still continuing to strive for through the 1115 is to have a data-informed continuum of care. While most of you all recognize and know that we are still working towards that goal, data is always something that we try to incorporate and ensure is informing at every level the way that we engage in our system of care, from our Medicaid through our grant administration. So while it is not one precise element of what we were able to solve, it is always the first step in moving our continuum forward and as we continue to engage moving forward.
I think that's great. I mean, one of the things that, like, one of maybe the themes of the day has been that you need the stakeholders to have this kind of shared philosophy that data is critical to decision, and the data should flow freely to the appropriate providers and sources so they can use the data to make good decisions. And I'm really struck that as you're all answering kind of what is the data that solves the problem, we're not talking about like a lot of different complexities of data. We're talking about like a patient roster from a practice. We're talking about real-time events from health systems. We're talking about vaccination records, which flow freely in and out of the backtrack. And then suddenly, because you were thoughtful to ask for things like race and ethnicity, you can also zoom out and look at populations to make sure we're not having access disparity issues. And because you have the kind of real-time points of contact, if and as you do see those equity and access issues, you can work with the community to solve them. Because now you're measuring things immediately to based processes. There's probably a million more examples of like a piece of data that's not that complicated, it can flow through the healthcare system. It also, and I do this on purpose, I make it sound very easy. But we also know that not all data is that easy, not everything just kind of flows freely. So maybe to be fair, we should talk about what barriers you have with data and either how you did solve them or maybe haven't yet. We should all talk through what we could do to solve them.
Since the mic is in front of me, I will start. Again, it's not going to come as any surprise to anyone in this room, given the number of conversations about behavioral health and the lack of data is, again, as I started with, the data heavily informed what we did in the writing of the 1115 from a number of different sources, NISDA, Purvis, and epidemiological data to really inform where there were gaps in the system and where there are disparities in our continuum of care and how those are unfortunately and disproportionately impacting parts of our community. What we had hoped and what we continue to strive for is the use of data to inform how we move forward. And that was the hope that the Administrative Services Organization would come in and provide us with a robust set of data metrics that looks at a multitude of different elements that help us to determine, is our continuum of care moving forward? Where are there gaps in the continuum? And then how do we share that data with our behavioral health providers so that they can make meaningful change and that we can then partner to ensure, are there elements that we as the state can help to assist with, and then really to focus in on in-home financing in a graded manner, both Medicaid and our behavioral health grants, to shore where those gaps in the system occur. We've not achieved that goal, but we've not abandoned that goal. That's where the ongoing conversation with our partners and the data modernization efforts that we are currently moving forward continue to be critically important. The efforts that are moving with our AKA system that really has been the backbone of the Division of Behavioral Health and how we use data, while it is a series of inputs and outputs, and it doesn't give us the level of outcome data that we prefer, still allows us to engage and move with some level of being data informed, and it helps to move the vision of the division of behavioral health. And the vision of behavioral health is to be able to engage at the right time with the right level of data. And that's to ensure that we have whole person care. Right now, at this early development in the 1115, we started with a collection of data that informed how we will move forward. But as we continue on those steps, it is through partnership and just a revisioning of how do we bring that data. Because if we're unable to move forward from where we initially felt that we would be able to get that data source, then our system starts to stall. And the individual, it is the person that becomes caught in that crosshairs of what we would like to achieve and then where we have failed. But I don't believe that we're at a point of failure. It is how do we revision and retool what's in front of us, understanding that data has to be accessible at both the provider level and the state level as we continue to think about and engage and drive our system of care in a way that is responsive, both community-based at all levels, upstream, at mild to moderate level, and not forgetting, and it's sometimes it feels uncomfortable that an individual will engage at an acute level of care. But we want to have the data that informs from that acute level of care, how do we re-engage back in the community to ensure that there are the right levers to pull, that there's the right access of care in their home community. The gaps that we currently experience with a lack of data are something that we can all just lean into, and we can talk about how we change that. It's more than just talking about how we change. It's coming together to say what is available, how do we pull that data forward, and then how do we recognize the importance of what has been used to inform the system of care. So while the barriers feel sometimes insurmountable, we also have to take a minute and step back and think about what has informed our system, and then how have our providers really stepped up to ensure that they're consistently engaging and that we are reciprocating in what data we have available.
I can share a story from within our network that we captured in one of the data scans from last year. The Hope Coalition in Sitka has worked with a number of other community members to implement a school survey each year. And in part, this was to respond to data specificity issues in certain respects that the YRBS was not capturing, or the school climate this survey was not capturing, because it was too small a population. And so certain demographic factors were not able to be queried against other answers to those to the survey questions, surveillance questions. So the Hope Coalition worked with a number of other partners to implement their own survey in the school system in Sitka that has been wildly successful. They have an 85 to 95% response rate, and they were able to uncover a unique pattern in Sitka that was happening, which was that younger women or I guess girls and young women were actually increasing their substance use at higher rates than any other demographic group in the school system, which is an odd pattern in many ways, public health wise, that would not have otherwise been uncovered if they hadn't kind of taken on that community level data collection and been able to match those very specific demographics with certain questions in surveillance data essentially. And then they were able to directly respond to this with programs and education within the school system, as well as within the police department, behavioral health services in Sitka, and those multi-level response organizations to pretty much immediately respond to that issue that become obvious through the data. So I think that that's a really powerful example of community level data that allows the community to immediately respond.
I might add, when we're talking about challenges, for us, when we were presenting this potential program to organizational leadership, a big challenge that we had was to convince leadership that this was data we needed. And also to convince providers this was data we needed. So kind of to Dr. Quinn's point earlier today about being the holdout that doesn't join the program or whatever that was. There's, for us, when we were talking about like, this is the data we need you to allow us to gather this data. It was not only a question of utility, like how are we going to use it, where is it useful, but it also represented a change in how we've always done things. And as we all know,
And, you know, we have some antiquated systems, we have some antiquated ways of practicing sometimes that don't necessarily reflect what's truly maybe going on with the patient, or what's needed for the patient. So I will say those were some of our challenges. Obviously, we had some really great discussions and overcame those challenges. But to convince an organization, and even then you also think about our organization that is a tribal organization, and we're saying this is good for our people as a population. That took a lot of conversation, but we got there, but still, a lot of work.
I think one of our biggest challenges, and I don't think we've fully solved it yet, is how do we get our peers so that we get that discrete data easily back into the system. You know, recently we've had a lot of people join the HIE, especially the CIN of Envoy, and that's amazing. That's a first big step. I mean, you know, for the few that weren't connected to the HIE, felt like you're the only person with a fax machine. You're like, and so now it's there. Now we starting to have that, you know, that critical mass of where it's really useful data, and it's amazing. And but I still think, you know, Lisa pointed this out, and I think it's the biggest challenge. It's still not as easy as faxing, right? There's a button inside your EHR, right? It pulls open a form, fills in all the data, you write your referral, you do it, whatever, you do your auto replace text, it does your whole thing, and you send it off, right? It's like a single button thing, right? That's much harder doing CCDA or getting doing a discrete secure message, right? And then importing that stuff in and making sure your line codes and snowbank codes are all matched up so it comes into your system and actually is useful data, right? It's really, really challenging. So like what we've done is we've gone to all of our people that we refer to the most and said, hey, you know, can I show you how to send it CCDA in your system, you know, or something like that. You're not connected to the HIE, so maybe, you know, have thought about doing that, you know, or here's how you do it. We've met with a lot of people who really want to do that. They want to share it. I think that it's a lot on the workflow of EHRs and the tools out there to be able to get that data communicate, especially like for referrals, other siloed organizations into your system in a way that is useful. Because if I just have a fax document of, you know, allergies, it doesn't really do a drug to allergy or drug to drug contraindications inside my EHR, or if it's only the HIE and my other stuff is, and I write the prescription inside my EHR, it's not going to interact like that. So I need that data inside my EHR. And so having a mechanism to easily import that stuff into the system is going to be key. We hire our medical staff just to make sure that we do that. And so that we pull CCDs down from the HIE, the hospital, every time they discharge somebody, automatically sends us a CCDA automatically. So we're able to import all of that diagnosis codes, medications, everything. So all that data is useful. I just think that once we get a critical mass of everyone doing that, it's going to really make a big change in the community.
I think that's a really helpful point. So we're hearing that creativity is needed to understand which data we can use for which purposes. That's probably never the best data in the world, but you can figure it out. We're a little open to being flexible. We're hearing that we have to have a lot of conversations. There's a level of transparency, which is essentially change management, which is what this is a discussion about. But it also has to be essentially the easiest path, because very few, if any, clinicians I've ever met have extra time in their day to do more things. And so we want to figure out how to make it easier. We have other examples. That was a really helpful one, Chad, where we put data in the workflow, or maybe Sarah, this could be for you, across like vaccination data and programs. Give me good success stories about how you can make it simpler to use, more high-tech interoperability standards.
You know, we're trying, and yeah, I was thinking about everyone talking on the panel and sharing. I feel like we're right there with you on collaboration and communication, and that change is really hard. You know, it's easy for the immunization program to say we're now requiring race and ethnicity data, but the reality is if we're looking at over 40 different unique EHRs that need to change their workflows and how they're transmitting data to us and hundreds of healthcare providers who are submitting data to us. So it takes a lot of communication and teamwork and testing to make sure all of those systems are talking to each other and that it's working well. And it's hard, you know, it takes time to make these changes, but I think the end result is everyone can serve Alaskans better in their healthcare. The other example I was thinking of is with Docket. A person Docket account matches to Backtrack based on their email address or phone number. Well, guess where a big data quality problem is in Backtrack? It's in people's email addresses and phone numbers. So really working through that with education and communication too, both with our healthcare providers who are entering patient data into Backtrack, but also it's come to the point where we're talking to Alaskans about that. We have a system now where if someone wants to use Docket, they can outreach if some of that information needs to be updated or is missing. And so I think that gives really that power of their healthcare record into the individual patient's hands. So I'm excited about that, that there's a way to improve a person's individual record. They don't have to go back to their doctor to get that fixed again. So it's a challenge and it's a process. And I feel like when we solve one problem, kind of the next one pops up, but we're making progress and moving forward. And it's great to have such great partners in doing that.
We can't ask for much more than at least making progress, right? Moving forward, that's better than the alternative. You also brought up a really helpful point about patients. And so as we think about kind of the free flow of data, we instantly should have a lot of privacy concerns. There's probably a necessary patient engagement piece. Does anyone want to talk about if and how patients are brought into the conversation, or how you brought patients into your specific programs?
Definitely, you know, it's been interesting with being pediatrics, because now we have minors that become adults, you know, and so how do we control that parents' access that is no longer should have access to it as the patient becomes an adult. So we, you know, implemented like a proxy type system, like our patient portals and stuff like that, so that parents are able to see the patient's record, but as soon as they become an adult, that automatically drops their access off. And we're also able to limit, you know, protected health information, behavioral health, STDs, and other type of reproductive type things that aren't allowed to be shared with adults through these Alaska statutes. So I think being creative with what you have, the tools that you have, and figuring out how to do that has been really good. So now our patients, we try to get them to start to learn how to use the portal, schedule their own appointments with their parents through the portal as they get older. So then as adults, they are learning how to use that technology and be engaged in their healthcare from a young age.
I can address that question from two fronts. Behavioral data will be made available for patient access through the interoperability project. So all of our Medicaid claims data, as well as some limited clinical data, will be made available. However, that your question did spur a moment of kind of introspection, where there's a gap in our conversation around data that we've not included patients directly. And so it's a very good question and a great moment.
That keeps me up at night also. As we make data available to patients, keep patients engaged, understand their data, and use somewhere to get it. And that's a big conversation. And unfortunately, in my experience, the patients who are seeking their data are not the ones using the emergency department for it. The ones that have the sport physicals that they want to get their kids in. That's why back to the douche. Patient comments or anything else, quite frankly, or questions also.
I will mention the way that we have engaged patients in the ROM process, the outcome monitoring process is, obviously it's part of our informed consent upfront. The thing I haven't mentioned on this panel is part of ROM is to actually record sessions. So our clinical director in clinical supervision with clinicians says, let's review the tape. If we're seeing that a patient is deteriorating, let's review the tape and see what's going on. So that's that real-time piece, right? And then our clinical director can then work with the clinician to say, right? Maybe we adjust here or here. So the other piece of that then is at every session, the patient is filling out our outcomes measure. That's actually, and I don't know if Sherry's still around, but she was talking about, you know, admin burden, and admin burden is all this kind of not useful stuff. But in terms of how we see the OQ, which is our outcomes questionnaire, that is a necessary part of a piece of paper that we administer every single time the patient comes in, because then what the clinician can do with the patient, say, hey, I see that you noted this on your questionnaire, what's going on with that? And what that represents is the patient's, again, the patient's real-time concern. So a patient can come in and be diagnosed with depression, and we can do a treatment plan that says, okay, we're gonna treat your depression. But what that outcomes data says every single time they come in is where the clinician can then go with the patient that day, because they're reviewing it before session. So again, that kind of real-time piece, and the patient is actually part of that process, that they understand what that means to say, yeah, I did feel that going on, right? So it's a real-time usage and integration into the session.
We should probably like reflect for a minute on the level of trust and transparency that it takes to film a session, review the session, discuss the session with the patient, and then also discuss the session with the provider in a way that is mutually beneficial and not judgmental.
This is not for the faint-hearted. But the truth is, anyone who's ever been through a clinical counseling program, part of your study is to review and record sessions. And that's actually part of your educational process. So really, when you think about this, what we're doing at Canada is we're saying, yes, this is a clinical program, you know, we offer psychotherapy and all these things, but it's a training program too, right? Because we want you to be the best clinician you can be. One of the ultimate results that we will get from our ROM program is the clinical director will then say, okay, for this clinician, I know what their training plan should be. Because time and time again, we're seeing maybe this aspect that maybe they need help with, right? So it's, but you're absolutely right. A lot of people were like, you want us to do what now? You want us to record what? And you want to watch it, what? But that's the standard of practice that we are trying to achieve.
Do we have any questions from the audience? Experts up here that have the scars of data integrations and workflow changes.
I just had a quick question about the availability of the HIE data to be able to use predictive analytics to focus on improving outcomes at a regional level, tribal healthcare system, or at a state level. So how are predictive analytics being incorporated into using HIE information? What is the overall availability of that information to be able to use at a systematic level?
That's for me. Okay. So, and you can all comment. So I have maybe two ways to answer that. The first is that, and this is really kind of the evolution that Lisa talked about with health data utility. As the data is available through this estate asset that's governed and controlled by all of you, the data can be used for whatever you all think is appropriate and used for. And so if there's an accountable care organization or a health plan or a state or somebody else that really wants to take data, combine it, and do really important things with it, like develop predictive models to identify high-risk patients across various programs, you can and should do that. I don't believe that Healthy Connect has any plans to do that. And we don't really have a data scientists or expertise to do that ourselves. We have a data lake that has the data that can serve it up to people. I'm also have a funny bias, which is that like technology is not the solution to most of your problems. And I would say, not to be overly offensive here, but like, I'm not sure that analytics are necessary at this point, in the sense that all the physicians here can name all the ED high utilizers. We don't need data to tell us who they are. We just need data to tell us who their care teams are, when they last received care, who their payments, all that important stuff. Just like I don't need predictive models to tell me who's going to overdose. It's the people on Medicaid who already overdosed. They're the ones. So I think if we can figure out simple ways to use data in clinical workflows, we'll probably do much better.
Personally, I'm actually very interested in delving a little bit deeper into that conversation too, because of the lack of data that's available back to communities in Alaska, particularly like fairly small communities. And I think that kind of came to a head in some ways with COVID and not even being able to understand if you had a COVID case in your village because of the privacy concerns, sharing back to community members about COVID cases. And so I wonder if HIE is going to be able to, you know, get around some of those questions, or if they're going to be still subject to the same level of regulation and de-identification that basically, in effect, disallows many communities to not access their own data.
Make one more plug then for local control and decisions, because the clinicians need the PHI, they need all the patient details to treat patients. When you get small communities with very small populations, even if the identified data set is maybe not good enough for certain privacy, and that's up for you all to figure out. And Healthy Connect shouldn't give data to anybody with more information. Our questions, I think we probably have like 2 more minutes.
Mine kind of goes along the same lines, but what about when the patient doesn't want their data shared? They specifically go to a different doctor because they do not want to share with maybe their primary care physician. So I grew up in rural Alaska, and that's a thing, you know, you go to Anchorage, but you don't necessarily want it to be in that town.
Yeah, so this goes back to A, the patient's right to opt out of data sharing, but B, the challenge with patient engagement, because if the patient doesn't know they can opt out, data flows. But I agree, it's very important for patients to right to opt out. No questions or comments? On the chat? Okay, we will ask one more question, and you can maybe either of these questions, depending on where you want to go with it. If you could ask the HIE or some magical policy to do one thing, whether it's implement a policy or a new piece of technology, what would it be? Everyone's got an answer.
Mine would be similar to what Backtrack did. I think that, you know, like I mentioned, I felt like we were the only ones connected to it. We had the immunity data and our immunization data for years. And once they required everyone to connect to it to receive state-funded vaccines, I would wish that we do the same thing for the HIE, that we somewhat require everyone to connect to the HIE, because it's that data is so important for that holistic care of that patient. So I wish that we would have everyone connected to the HIE.
Maybe this question is for the magical policymaker. So we recognize that data enhances the quality of care and makes care more accessible when we understand where the needs are, but how do we ensure that we have the level of data metrics that we want without increasing administrative burden on the providers that are administering that care?
I think I'm gonna have to echo that. When I think about the magical policy question, it is, for me, more of how do we switch focus to person-centered care, away from boxes for boxes' sake, and how do we actually use actual data to inform what that quality is, rather than assuming that we know.
Sarah, I've left you from afar.
Sure, I'm glad I have a few minutes to keep thinking about it. You know, I think one challenge we have in our immunization data that I think we all can have a piece of an answer to maybe is a denominator challenge, quite frankly. And I don't know if the HIE or through different state partnerships, we can come up with the ideal solution to knowing how many people in Backtrack are actually still living in Alaska. That's my ask for our data quality partnership.
Great, and maybe that's the right idea to end on, that if we compare what problem we're trying to solve, it might be a simple sounding problem, like how many people live in Alaska? But let's focus on those problems. Let's keep it simple, and we'll keep moving forward. So thank you to all our panelists for being up here. We have Carrie and Georgiana coming up to.
You made it. So before I get into my closing remarks, I need you all to stand up. It's been a long, cerebral day, and turn to someone that you don't know or that you haven't talked to all day and share something you learned, something you're mad about, something you're curious, share something about your day to like get the juices flowing, get the energy back up, or you can sit in the last chair.
Little yoga.
Still working. Yeah, all right. Test. Oh, here I am. All right, I promise this will be quick and painless. But first of all, I want to thank you sincerely for joining us. I know many of you, this is the first time you've been in public wearing pants with other people in a conference room all day, so thank you. And learning hopefully something that you may or may not have known. Special thanks to Healthy Connect for making this day happen. Super special to see you all in a room as well as have the virtual folks with us. So I'm Carrie Pykoch with Alaska's Department of Health. I'm joined with Georgiana Page, the Interim Director of Healthy Connect. We want to extend that thanks. But first, I think it's important as a new Alaskan, we want to honor and acknowledge the conference is hosted on the traditional homeland of Eglutna, Dena'ina. Healthy Connect and the state of Alaska Department of Health want to thank and acknowledge the Dena'ina people for this land and recognize their culture and traditions. In addition to the land acknowledgement, both organizations are focused on ensuring healthy and equitable communities to support Alaska's health goals and strategies as outlined in Alaska 23. To achieve these goals, health providers, state, community, educational, all sorts of organizations, and tribal health partners need data, information, technology, and workforce, collaborating and working together in harmony. And it's not easy. This can only be done through collaboration, innovation, and the 8-syllable word, interoperability. If you write speeches for lieutenant governors like I have, you have to go through and spell that out, a lot of syllables. But it has to be focused on shared goals and shared problems. Doing these things in abstract, like, oh my God, we'll never get there. What is data governance? But you can get it done, and very thankful for all the time our speakers and you all have spent today thinking through these things. As you transition and leave for the day, I hope you have time to reflect on ideas, questions, and connections. Dr. Zink stole my closing, so I'm gonna, instead of ending with one word that I want you to leave with, I'll leave you with a few words. So the first word is, I want you to leave with reuse, which means to reuse again. In Alaska, reuse is part of every day. From fishing to grocery stores, effective reuse lowers costs and adds more value. So I want you to think about how you can reuse data and technology as part of your day-to-day efforts. Why create something new and start from scratch when it already exists? What systems can be re-leveraged or better aligned? How do we govern this? How do we have these difficult conversations either loudly, very quietly, and saying why are you sharing your data with me? Or as Lisa alluded to, there's going to be some regulations that require doctors and providers to share information more broadly. Otherwise, you may get a penalty from data blocking. So those things are real. I believe statewide health data utilities such as Healthy Connect is facilitating is a great place to start. The other word that other couple words I want to inspire you to leave with is reimagine. So going from paper to electronic systems is it's a wonderful thought exercise. You get something new, but going from an electronic system to another electronic system, or going back to the one that you thought that you used and it's changed, that's a very difficult mental exercise. It's even harder. It's like trying to lose weight. You tried something and you try it again. You have to stick to it. So my hope is that you can reimagine health information exchange and shift away from kind of what you experienced and felt 10 years ago to thinking about what it could be as a health data utility. So that's the second word. So reuse, reimagine, and the last one, because in Alaska, everything's relationship based, rekindle. We'll rekindle those relationships that you had, or because of the pandemic, we've been all forced into boxes and squares. Get out there, have coffee, rekindle those relationships. So with that being said, it's my honor to pass this to Georgiana, leader of a remarkable event and organization, to close you out.
I'd like to echo my thanks to all of you for joining us here today for our first annual Health Information Exchange Summit. The stories, opinions, and dialogue shared here today is inspiring, and I believe that we have a better shared vision of interoperability and how we can leverage both new and existing technology to improve health outcomes for Alaskan patients. Health information exchanges began as a simple sharing of information through secure technology to flow information back and forth. It's clear HIEs must evolve to a future state that provides tools and resources to support the health of each community in collaboration with the community. And I feel Healthy Connect is up to that task. I'm excited about the next chapter for the Alaska HIE as we broaden our capacity to support initiatives such as social determinants of health, health equity, value-based care, referral management, and more. I hope this summit is just the beginning of our work with you and with others throughout the state to move further forward with interoperability, collaboration, and innovation for healthier Alaskans. Finally, I'd like to offer my thanks to our co-host for this event, the Department of Health, all of our wonderful moderators and presenters that joined us here today, our Healthy Connect board and staff, and our contractors, Crisp Shared Services and Incentive. So thank you all again for coming today, both in person and virtually. We really appreciate your support. Thanks so much, everybody.